only some masking on clinic or hospital or clinic.
Okay.
Another all free.
Very good, very good, very good. Very important that we start our life again.
Yeah. Long time. We empty maybe 3 or 4 years.
That's right.
Yeah.
That's right. We have to do some nice, beautiful meeting now. Okay.
Yeah.
And I'm doing one meeting in January. I wish you can come and join me. I
January.
will see if I can. Samay, I'm doing with Samay. Samay is the boss, like always. And I wish Samay, let us invite Dr. Kim for our meeting.
Yes, sure. Sure. It will be our pleasure.
Thank you so
Joe
much.
will come also, if he can.
We will invite John as a special guest for our meeting.
Please. Send the barge for me.
He says, I don't want to leave Miami. He says, I don't want to leave the beach. It's a
hard place to leave, Atul. It's a hard place to leave.
Yeah, no, wonderful. It is a heavenly place, at least what I can see on the screen, what this beach is.
Well, you've been here a few times, right?
Yeah. Miami is a wonderful, wonderful little town.
Yes, it is.
Okay, John, we can start now.
Yeah, hold on. I'm putting on YouTube there, Sam.
Okay.
And then we can start. And is Malcolm's video being played? Atul's first, right, Sam?
Yes, John,
yes, Professor Goel first.
Okay, we start with the king. Okay.
Yeah.
Okay, let's let me here. Okay, we're all set. Okay, Ken, ready, Sam? That looks great. Your background looks great. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from sunny Miami, home of Neurosurgical TV. We have day 2 of the collaboration between EWNC and Neurosurgical TV. Yesterday, we had a dynamite lineup of brain talks. Today, we're concentrating on spine, and we start off with the king, and I'll let Sam introduce the king. Go ahead, Sam.
Of course, Professor Goel has an contribution in neurosurgery, and all of us well-known figure for all of us, and he don't need any introduction. Welcome all to 7th anniversary of EWNC Academy Spine Day. Today we will focus on neuroendoscopy and some great issues about spine interventions. And we will start with the king, as John said. Professor Atul Goel, please start sharing your screen. Thank you.
Thank you, Sam. Thank you, John. And John will completely agree that Sam has made a huge contribution to the field of neurosurgical education. And this forum that he has initiated is becoming more and more powerful. And also, Sam is, the way he's organizing, the way he's working, the way he's promoting this subject of neurosurgery. I have a feeling, Sam, that you will be the best candidate to lead the World Federation of Neurological Surgery someday, if not soon, after a few years. So you work on those things, Samay. Okay? So, can you hear me, John?
Yes, sir.
Yes.
Okay. So I'm, I have presented this lecture on several occasions, and I want to present it again. And I want to present the same things again because my feeling is that this is a complete revolution in spine surgery. Complete different spine surgery. So I am going to talk to you on new spine surgery. Looking beyond decompression. We all know that whenever we talk of spine, we talk of compression and we talk of decompression. That is the treatment. That is the issue. We look at MRI, we see at compression, and our aim of surgery is decompression. So I am going to give you a different version of this concept. And I am saying that don't look at compression and don't do decompression. You find out why there is compression and treat that why. My concept is compression is never an issue and decompression is never a treatment. So this is a hugely different kind of philosophy that I'm going to present before you. More important is all the statements, everything that I will say has been published. So you in very big journals. So you please remember this. So this is human body, this is a bird, and I have shown this slide now for several times. And I have to say that movements are so important for life and for activity. And when this bird moves, if there is a problem in movement, shoulders can become a problem. If this horse moves and there is a problem in movement, shoulders and hips can be a problem because they work on 4 legs. On the other hand, when the human body can have a problem, there will be a spinal issue. If the muscles of the spine are weak, there will be spinal weakness. And this weakness of the muscles due to disuse, abuse, injury forms the basis of problems of number of issues related to spine. That concept I wish to present before you. I wish to introduce an absolutely novel concept of vertical facetal instability. When the muscles become weak, there is a problem at the facets. All the muscle activity is focused on the facets. And when the muscles become weak, there is weakness at the facets. We become short. There is a listhesis. If you look at your grandfather, he will be shorter than you. Why he is shorter than you? Because there is a telescoping of the spine. The spinal segments come closer. And that is due to weakness of the muscles. And that weakness, I label it as vertical facetal instability. And I have no doubt and no hesitation to say that this is the point of genesis of spinal spondylotic disease. Not this degeneration, not this space reduction, but vertical facetal instability. Compression is never an issue. Compression is always secondary. Compression is always protective, and compression is always reversible, and decompression is never the treatment in both cranio-vertebral junction and subaxial spine. First, I will like to go on cranio-vertebral junction. So if you see this slide, there is Chiari, there is syrinx. Here there is basilar invagination, there is syringobulbar, syringomyelia, there is Chiari. There is severe basilar invagination. There is not much Chiari, but there is syrinx. Here there is another case of severe problem in the cranio-vertebral junction. Platybasia, assimilation of atlas, C2-3 fusion, and basilar invagination. There is atlantoaxial instability and Chiari here. There is no cranio-vertebral junction anomaly and there is Chiari. So the question which I'm trying to put before you is, are these problems different? Do all these patients have different kind of problems? And whether all these patients need different kind of treatment? My question to this answer to this question is that all these problems have the genesis is on atlantoaxial instability. Atlantoaxial instability is the primary issue, and all these Chiari, syrinx, and all these other are secondary. They are protective and they are reversible. So there are issues of chronic atlantoaxial instability, chronic instability and acute instability. There are 2 types of instability. Acute is following trauma. Chronic is like when the instability is for 20 years, subtle instability. It may not be identifiable on imaging. But what happens is there is a natural protection in different formats, in different ways. Like some patients develop basilar invagination, some develop chiari, some develop syrinx, some develop basilar plus syrinx, some develop platybasia, some develop clipal file anomalies, some develop C1 assimilation, C2-3 fusion, various kinds, torticollis, short neck. All these secondary maneuvering happens by nature, which is meant to protect the neural structures. So chronic atlantoaxial instability is the father of all the problems. Chiari, syrinx, external syringomalia, short head, basilar invagination, bifid, arch of atlas, C2-3 fusion, clipal file abnormalities, whether they are present discretely, like chiari is present only chiari, or chiari with basilar, chiari with syrinx, chiari with external syringomalia, chiari with short head. Whenever all these anomalies are present discretely or in cohort, they indicate chronic atlantoaxial instability. All these things are not pathological, they are protective, and they are important. All the movements of human spine are focused on the facets. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common spinal instability. More the mobility, more the possibility of instability. Atlantoaxial instability is most under-recognized and under-treated clinical entity. For the first time in the literature, we said that when there is facetal instability due to muscle weakness, muscle injury, and we hypotheticated that intrafetal injury can also be a cause of facetal listhesis, like lumbosacral listhesis, C1 over C2 listhesis is the cause of basilar invagination. Instability is the cause and stabilization is the treatment. For the first time in the literature, we said that fixed atlantoaxial instability, there is nothing like fixed dislocation. We can open the joint and reduce the dislocation. The instability is mobile, it is pathologically mobile, it is hypermobile. It looks fixed on dynamic imaging. There is no movement, but it is not correct. And the instability is the issue and stabilization is the treatment. So these kind of anomalies were treated by decompression from mouth or decompression from behind. So we said for the first time that these patients need stabilization. There is no role for decompression in these kind of situations. Similarly, basilar invagination is not a fixed anomaly. There is unstable C1-2 articulation. Realignment and stabilization is the treatment. We said this for group A. In 2004, for group B, we said that there is decompression is the treatment. So these slides I have shown on several occasions, but they are so important in the history of this subject that group A basilar invagination, now the whole world is treating by realignment. And not many people do decompression or transoral surgery is not such a common form of surgery. So facetal listhesis is the issue. Basilar invagination is secondary. It is protective and it is reversible after stabilization. That is very important issue which I have discussed. Another thing which we have recently talked for about 15 years, the issue of central or axial atlantoaxial instability. In chronic situations, chronic atlantoaxial instability, the instability may not be identifiable on imaging. Instability is subtle. Imaging may not show the instability, and this may be a very huge revolution in cranio-vertebral junction surgery. So chiari, syrinx, degenerative spine, OPLL, Hirayama disease, all these cervical degeneration can have central atlantoaxial instability. So carefully see this slide. You see how there is listhesis of C1 over C2. Listhesis is the issue, stabilization is the treatment. Here the C1 is going behind, there is retrolisthesis. This is unstable. This kind of huge basilar invagination, there is no need for decompression. It needs stabilization, even if there is no compression. Even if there is no atlantodental interval disturbance, C1, C2 fixation is to be done. Type 3 is when the facets are in alignment, there is no atlantodental interval disturbance, presence of Chiari, presence of syrinx, presence of assimilation of atlas, presence of platybasia are all clear, solid indicators of C1, C2 instability, and you have to do C1, C2 stabilization. Basilar invagination of type A and type B both are secondary to chronic atlantoaxial instability. There is no role for decompression. Stabilization is required for both group A and group B basilar invagination. Instability is the issue. Atlantoaxial instability is the issue, and stabilization is the treatment. Even when there is no atlantodental interval disturbance, no facetal malalignment, presence of Chiari, presence of external syringomyelia, presence of basilar invagination is a clear, solid indicator of atlantoaxial instability, even when there is no compression of the cervicomedullary cord. So we should look at the facets, and we should understand that this is an unstable situation, and this situation needs one treatment, and that treatment is stabilization. Decompression is not the treatment. In this situation, you see there is subtle movement. When there is C2-3 fusion, even if there is no Chiari, even if there is no syrinx, it is atlantoaxial instability is the issue. Here there is assimilation of atlas. Even when there is no other problem in the spine, no compression, no other thing, atlantoaxial stabilization has to be done. So Chiari, syringomyelia, and basilar invagination are all secondary issues to atlantoaxial instability, and atlantoaxial stabilization is the treatment. For Chiari, the whole world is doing decompression. My answer to that question is decompression is negative. Decompression is never going to be helpful. It is going to be harmful. So this is an article we wrote a few years ago about our experience in 388 cases for all kinds of Chiari, not of course following tumors, following bifid spina, bifida, and following hydrocephalus, not those kind of things, but general Chiari and syringomyelia and basilar invagination, atlantoaxial stabilization is the treatment. So we have got a huge experience, and there is no controversy in my mind. And those young people who are listening, you have to understand that you learn C1, C2 stabilization, and decompression is a negative operation. Syringomyelia will reduce in 100% of patients. Patients will improve 100% after immediately post-operative. Many of these syringomyelia will reduce after 24 hours imaging, but 100% reduction in the syringomyelia if you do after about 6 months or 1 year. So this kind of Chiari and syrinx, there is subtle basilar invagination here. Stabilization is the treatment. Decompression is negative problem. There is no compression at the cranio-vertebral junction. There is no facetal malalignment. Stabilization is the treatment. So we have got now several hundred cases where these kind of syrinx and Chiari. Just look at the facet. Even when the facets are okay, you have to do stabilization, and you have to see the magic clinical results. So Chiari is secondary, Chiari is protective, and Chiari is reversible. We said that Chiari is not a malformation, it is a formation, and it is like nature's airbag. Cervical fusions like Klippel file, assimilation of atlas, C2-3 fusions are protective. They are protective and they are secondary. Bifid is protective and secondary. Os odontoideum is protective and secondary to chronic atlantoaxial instability. When there is os odontoideum, don't look anywhere, just do fixation. When you see bifid, just don't look here and there. It is unstable C1, C2, and stabilization is the treatment. Multi-level cervical fusions, no compression. Bifid, no other problem. Do C1, C2 fixation, and you see a magic treatment. Syringomyelia is protective. It is secondary. It is due to atlantoaxial instability. This kind of syringomyelia, where there is no chiari, was used to be called idiopathic syrinx, but this is idiopathic, all right, but it is due to atlantoaxial instability, which is not seen on imaging. You do the C1, C2 fixation, and you see a magic. Musculoskeletal anomalies that are seen, like short neck and torticollis, are all secondary. They are all indicators of unstable atlantoaxial joint, and only stabilization is required. There is no other treatment required. So in central instability, when there is short head and short neck, there is torticollis. When there is short spine, there is kyphoscoliosis. So in this age group, if you see kyphoscoliosis, at least 80% of these kind of children have central instability, and you have to do stabilization. And in the immediate postoperative period, the breathing will improve. Breathing is, there is not a problem due to kyphoscoliosis. The lungs are not affected. It is the cranio-vertebral junction which is affected. You do C1, C2 fixation, and a magic can be seen. Central or atlantoaxial instability can itself be a cause of cervical myelopathy when there is no other issues in the spine. When you see syringomyelia without compression at C1, C2, you do C1, C2 fixation, no atlantodental, no facetal malalignment. When you see bifid, you do C1, C2 fixation, and you can have a wonderful smile. Now I go to degenerative spines. You see, atlantoaxial joint is the most mobile joint. Atlantoaxial degeneration is the most frequent form of degeneration, which we don't try to understand, and we don't realize. Atlantoaxial instability can lead to degenerative atlantoaxial joint. Now you see, there is, carefully, I want you to see this slide. There is osteophyte here. There is reduction in the joint space. There is buckling of the posterior longitudinal ligaments. These are not primary issues. This is due to weakness of the muscles, and there is a vertical spinal instability. You have to treat this instability. These secondary issues will resolve by itself. They are protective. They are naturally adaptive, and they are reversible following atlantoaxial stabilization. Ossification of the apical ligament, osteophyte formation behind the body are not primary events. They are secondary to atlantoaxial instability. Stabilization is the treatment. Retroodontoid pseudotumor, the whole world was doing transoral surgery or lateral surgery or inferior surgery. These are secondary. These are due to atlantoaxial instability. This is due to or look alike of osteophyte. This is secondary. You don't need to do resection of this. You treat by atlantoaxial stabilization. So for the first time in the literature, we said that retroodontoid pseudotumor requires atlantoaxial stabilization, and there is no need for decompression. So atlantoaxial instability is the cause of retroodontoid pseudotumor. So instability is the nodal point of pathogenesis of degenerative spine and OPLL. Retroodontoid pseudotumor, retroodontoid pannus, retroodontoid cyst are all secondary to chronic atlantoaxial instability, and stabilization is the treatment. Pannus, the whole world full of rheumatoid arthritis was treating by transoral decompression. We said that pannus is due to vertical facetal collapse. Buckling of the ligament, this is not a pathology. This is secondary, this is protective, this is reversible following atlantoaxial stabilization as soon as in the immediate postoperative period. So facetal instability at the C1, C2, now we have talked about for a long time. Nobody really understands the facets of cervical and subaxial spine in the lumbar spine. Weakness of the muscles of the neck can lead to listhesis at the facets. Just carefully see this slide. Reduction in the intervertebral body space, buckling of the disc, osteophyte formation are not primary events. These things are secondary. They are protective. These are reversible, and they are indicators of instability. Stabilization of the spine is necessary. These are secondary and these will be reversible. So about 15 years ago, we introduced this treatment of facetal distraction. And this distraction, we thought that listhesis is the issue, you distract and stabilize. So for the first time, we said that decompression is not the treatment. You do distraction, reduction, and fixation. And this was a big leap in our understanding of this problem of spinal degeneration. And we introduced a new hypothesis about spinal degeneration. So at that time, we did several cases where there is ligamentum flavum buckling, disc space buckling, multi-segmental distraction, reduction, and fixation, arthrodesis as treatment, no decompression. So arthrodesis as a treatment without decompression in degenerative spine was first introduced in this paper. And we did several cases at that time. You see there is multi-segmental issue, and I did multi-segmental distraction and beautiful clinical results. So this was published as cover page of Journal of Neurosurgery about 15 years ago as facetal distraction as treatment. So we had several patients where we did facetal distraction without any form of decompression and absolutely magical clinical results. So what we have said is that we should look at degenerative spine away from the disc. Disc is divine, disc is spiritual, disc can never go wrong. Don't blame the disc for all the problems that you have in your spine. Blame yourself that you have not made your muscles strong. Same concept we use for lumbar canal stenosis, where we said these kind of bulging are not due to disc problem, they are due to vertical facetal instability, and we introduced this intra-articular spaces, and this article was published in Journal of Neurosurgery. So a new concept. But as we went on further, about 10 years ago, we said that even distraction is not necessary. Instability is the issue and stabilization is the treatment. Only fixation of degenerative spine was introduced as a new concept. And more recently, we said that muscle weakness related spinal instability is the cause of spinal degeneration, and spinal stabilization is the treatment. So you can see from the title, what a magical title published in World Neurosurgery, that no decompression. So we have several cases like multi-segmental degeneration, and after 18 months of surgery, the entire degenerative process has gone, and only fixation, no decompression. Only fixation, no decompression, and you see the spinal cord completely returns to normal, no decompression. Most important thing in spinal degeneration is to identify which levels are unstable. It is very critical. It is not on radiology, only 2 levels are appearing here, and I have done 4-level fixation. And you see after some time, why 4-level? You please read my article on this subject as to why and what. Which segment is unstable on clinical grounds, on radiological grounds, and all intraoperative understanding. Another very fantastic, beautiful thing in degenerative spine is nobody talks of atlantoaxial instability. Subaxial vertical spinal instability is very frequently associated with atlantoaxial instability. And you see there is central instability even in the absence of compression by the odontoid process. Multi-segmental spinal degeneration can be associated with atlantoaxial instability, and multi-segmental stabilization is the treatment. You see there is instability here, no compression. You have to include atlantoaxial joint in the fixation construct, no decompression. We have recently changed our thought. We don't include C1, we do C2-3 fixation and cut all the muscles of the C2 spinous process, and we have introduced a new technique of C1, C2 fixation. Degenerative spine, when the patient comes with severe myelopathy, the treatment atlantoaxial instability is frequently associated. When this patient comes on a wheelchair, on a trolley, you don't do decompression. It is multi-segmental instability associated with atlantoaxial instability, and you have to do atlantoaxial and subaxial stabilization. Same concept, this paper published in Neurosurgical Focus. We said that lumbar canal stenosis, only fixation, and futility of decompression. Very huge paper, very important journal. Lumbar canal stenosis, the whole world treats the stenosis, whole world treats the compression, but nobody treats the instability. You treat the instability and there will be no need for decompression. So osteophytes, the whole world wants to remove the osteophytes. I am saying you do only fixations. Osteophyte is secondary, osteophyte is protective, and osteophytes are reversible. So these multisegmental osteophytes can disappear after multisegmental stabilization. And we have got several hundred cases now where the osteophytes have disappeared. More important is the patient will remarkably recover in the immediate postoperative period. Deformities are not primary, they are secondary. They are secondary to unstable spine. Identify where is the instability and stabilize. This patient needs atlantoaxial stabilization. The C of the curve will need stabilization. Here there is central instability. You have to include C1, C2 in your fixation construct. Another very maybe probably controversial, prolapse herniated disc is secondary to unstable spine. Instability causes prolapse disc or prolapse disc causes instability. Only stabilization is the treatment. This kind of prolapse disc, there is no need to remove the disc. You stabilize. Whether you want to remove with endoscope or minimal invasion, it is not required. Unstable spine, you stabilize, the disc will disappear. And this article was published in World Neurosurgery. I want you to please read this article. Similar concept we introduced for lumbar disc. If there is a disc, there is a huge disc, you do only fixation of the segment and this disc will disappear in very quick time. In 3 or 4 months, this will disappear. Most important is patient will recover remarkably in the immediate postoperative period. Last concept which I want to propose to you is OPLL. OPLL is the most difficult chapter in spinal disease. Decompression is the treatment. We said for the first time that only stabilization is the treatment of OPLL. This kind of OPLL, whether you want to come from front, whether you want to come from behind, how many segments to fuse, how many segments to decompress is the issue. I'm saying no decompression. These are secondary, these are protective, and these are reversible. So this is a brand new concept. I want you to think about it. I want you to maybe probably go deeper into this aspect and try to understand. Atlantoaxial instability is very frequently associated with OPLL. And there are several articles of mine where we have discussed about cranio-vertebral junction and spinal instability. You have to include atlantoaxial stabilization in the fixation construct. There is no role for spinal decompression. So atlantoaxial and subaxial spinal fixation, it can revolutionize the treatment of OPLL. Hirayama is another disease which is there in Japan and in Korea and in India. Nobody really understands. Instability is the problem. Central instability can be an issue. Stabilize and see the magic. So transoral surgery can be historical. Foramen magnum decompression can be historical. And any kind of spinal degeneration in decompression can certainly become historical in my view. So thank you very much, my dear Samay. Thank you, John. And thank you, my dear friends. I hope you have enjoyed this. And I hope you look into spinal disease in a different perspective. And there are issues in this which we will try to sort out together. Thank you very much, my dear Samay.
Thanks a lot, dear Professor, for this excellent presentation. Is there any question from panelists?
Yes, Sam, I see a couple, I think. Do you see the questions in the chat there, Sam?
Yes, yes.
Go ahead.
Muhammad Sikal asking about access. Any cases of thoracic spondylosis that was facet device?
I am still working on the thoracic spine, and I will come back to you on thoracic spine maybe after some time.
Okay. Thank you, Sir, for this excellent presentation.
Thank you, my dear Samay. And I'm sorry, yesterday there was some issue and I couldn't be there for the whole lecture, but I wish you all the best. I want you to progress and develop in this field of neurosurgery, and you are the leader, and no question, you are the future. Thank you very much, my dear Samay, and thank you, John, and
Okay.
best wishes to all of you.
Okay, Atul, your barge is ready to go back to your hotel.
Okay, okay.
Thank
Thank
you very
you.
much.
Thank you.
John, please make me co-host. Next speaker
Yeah, okay, okay, Sam.
is Dr. Rohit, and he is in attendees.
Okay, who is the attendee needs to get let in?
I will pick him up. Dr. Rohit is the next speaker. Rohit Dilat.
Dr. Lee?
Rohit.
Do you see him in the panel?
Yes, he just come. Okay, are you ready, Dr. Rohit?
Hello.
Hello.
Yeah,
It's
can
okay.
you listen me, sir?
Yes. Please start sharing your screen. Thank
Yeah.
you.
Thank you. Good evening, all. Many thanks to Dr. Same, Dr. Malcolm, sir, for invitation and giving me opportunity to talk. So let me start with the case of 55-year-old male who came to us with a history of severe left-sided upper limb radicular pain. There was tricep weakness 4/5 and tingling in middle finger. He was symptomatic for 2 months duration and had tried all form of conservative treatment. There was no relief. And as you can see in MRI that there was C6, C7 disc herniation and superior migration. And also there was C5, C6 left-sided disc herniation. So the treatment option was fusion versus non-fusion surgery in my mind. And the options were anterior cervical decompression fixation, 1 or 2 level, posteriorly foraminotomy, decompression discectomy, either open or tube and endoscopy. So I opted for endoscopic decompression using unilateral biportal discectomy. It is not moving. Is it going down? No. Okay, so as you can see that there is very well decompression of C7 root. The whole concept of only decompression by posterior method was to avoid fusion so as to avoid adjacent segment later on. In my mind, the indication for unilateral biportal endoscopy cervical spine is lateral disc herniation, disc osteophyte complex, posterolaterally myelopathy in 1 or 2 level, and the contraindications are central disc, OPLL covering more than 50% of disc canal and instability. So in traditional open foraminotomy, we find the field is very deep. We need to sacrifice many muscles and there is a lot of bleeding, which causes difficulty in vision because of bleeding, and the whole process is very morbid. Previously, I used to do tubular foraminotomies and decompression of root discectomies, but again, the vision was an issue because of bleeding. So after learning UB, I restarted doing posterior foraminotomies and non-fusion surgeries because it was a modified microscopic surgery. It is basically endoscopic assisted surgery where the lens and magnification are at the surgical site. And because of fluid, the vision is absolute clear and the surgery becomes very simple and safe. But before starting cervical endoscopy or cervical UBE, we should know how to read X-ray and IITE picture. We should know the midline. We should know the level because majority of our surgery is in AP view. And we know that our majority of pathology are at C6, C7 or C5, C6 level. So to mark in AP, C7 transfer processes are slightly bigger than C6 and they are pointing downwards. So anything above that will be C6, C7 disc. We should know the uncinate process because the uncinate process marks the lateralmost margin of the disc and beyond that will not be any compression. We should also know that V point is the point of junction between superior and inferior lamina, which is the landmark of blocking the working channel and starting the decompression. And we should also know the relationship between uncinate process and V point, because uncinate process is the last margin of decompression and V point is the starting, which will be slightly medial. From V point to we have to just go till the uncinate process and slightly beyond that, until that our decompression will be complete. We should know how to see pedicle in X-rays, because that will help us in marking portals, and we should know facet joints also, because we have to preserve as much as facet as we can. So we should know where the disc is and uncinate process. So this is the uncinate process, lateral margin of disc. All the paracentral disc and disc occiput complex are till here, and decompression lateral to this point will suffice our decompression. So no need to go beyond this point. The surgeries are done under general anesthesia and in hypotensive, so that our vision becomes clear. The main challenges during surgery is bleeding and angle of walking. The bleeding can be solved by keeping abdomen free, keeping the hypotension somewhere between 90 or 80, elevating the head end, which will reduce the venous return and bleeding inside, and keeping our working port outflow good. That will help in obtaining clear vision. To keep angle of working friendly, we have to keep our neck parallel to the ground, which will keep our disc vertical and it will square. So this is the position in which we operate. We flex the neck. We try to make it horizontal by elevating the head end. We will flex the knee and pad it. We will give contour traction at buttocks and head and traction on shoulder, so that our lateral view becomes clear and our level marking becomes easy. We have to keep abdomen free and check before draping in CM whether we can see epilateral properly or not. To make the portals, we have to square the disc, we have to mark central line, we have to mark pedicles, we have to mark lateral pedicular line and align 1 centimeter lateral to that. We have to target the spinolamellar junction. Caudal will be working portal and cranial will be scopic portal, and both the pedicles will be, both the lines will be touching the pedicle. So these are portals. Cranial portal is scopic portal and caudal portal is working portal. This is a triangulation. By needle, I am marking my level. This is the triangulation in AP view. This is triangulation is lateral view at C6, C7 junction. To make the working space clear, we have to use serial dilator. We can use RF to clear the working space, and our target is V point, as you can see in this slide. To keep the working space open, we can use dilators, fluid pressure and radio frequency ablation. And for fluid pressure, we can use natural drainage system, which will be gravity assisted, and we can also use pump. The pressure of pump should be between 30 to 50 millimeter of mercury. So V point is a point of junction between superior lamina and inferior lamina and medial point of the facet joint. This is our starting point. Starting point of our decompression, as you can see, diamond burr is at the V point. Steps of foraminotomy or decompression will be: first we have to decompress superior lamina, then inferior lamina, and then facet joint, and we can compromise up to 50%, 30 to 40%, 50% suffice. During drilling, we have to drill cranially and laterally using 3.5 or 4 millimeter spherical diamond burr until the ligamentum flavum is separated from the superior lamina. Inferiorly, we have to drill inferiorly and laterally till we see thinning of lamina, and we see inner cortex very thin, budding laterally towards the facet joint till we see separation of ligamentum flavum from laterally, and we see fat at the lateral margin of the ligamentum flavum. We should do all bony work before removing ligamentum flavum because it acts as a protective layer. The medial 1/3 to medial half of the facet joint is progressively removed, which prevents instability. So ligamentum flavum, as we said, until the lateral margin of ligamentum flavum appears to separate. After completing bony work using 1 mm and 2 mm Carrison, we can go for flavectomy. Flavum has to be removed in the end after completing all bony work because again it works as a protective layer during drilling and using Carrison. So after removing ligamentum flavum, we can see spinal cord, we can see root, and we can also see pedicle of superior, that is C6, and inferior, that is C7 in this case. So usually disc is situated in the axilla of the nerve root, which can be removed with the help of hook and disc forceps. In case of less space where the disc is collapsed, we can manipulate the disc with hook, and in some time we may require pediculotomy using burr so as to create more space to manipulate the nerve root. So after decompression, after discectomy, we have to check, we have to pass nerve hook, ballpoint nerve hook to see the adequacy of the decompression. So this is a small video of surgery. I would like to show that laminotomy of superior lamina. I will just quickly go through it. That is, ligamentum flavum is getting separated from here. Again, there is drilling of inferior lamina till thinning. Using Carrison, I'm removing inferior lamina, and as you can see, there is space is opening up, and spinal cord is visible below that. So after complete removing of bone and ligamentum flavum using hook, we can remove the disc. Yeah, I'm using hook to take out disc from the axilla of the root. And this completes my decompression. Thank you, sir. Thank you, Dr. Samay, for giving me opportunity to speak.
Thanks a lot, Dr. Cohit, for this excellent presentation. Is there any question from panelists?
Dr. Lohit Delat, can
Yes,
I give
sir.
some question?
Yes, sir.
Maybe in the cervical decompression, we worry about that is very dangerous to Cauda injury, but your lecture and presentation is excellent. How to prevent and how to keep the spinal cord and prevent the damage during the endoscopic cervical procedure?
Sir, that I discussed in during talk only. We have to keep our ligamentum flavum intact there only till completing our bony work, because ligamentum flavum work as a protective layer there. Once we are sure that our bony work is complete, as much as we want to remove the bone, we have removed.
Meaning that you're doing first, if possible, doing the outside in over the top technique.
Yes, sir.
Yeah, that's great.
Thank you, sir.
Thank you so much. Okay.
Thank you, sir.
Thanks, Dr. Cohit, for this excellent presentation, and Dr. Kim for comment. And now we will shift to the next speaker, Dr. Shidam. Please start sharing your screen.
Hello.
We see your screen, but we don't see you.
Okay.
It's okay.
Hi, dear colleagues. My name is Dr. Çiğdem Mumcu from Turkey. I'm so excited to participate in this webinar. Thank you so much for inviting me. Today, I will present biportal endoscopic spine surgery, pitfalls and early learning curve. Unilateral biportal endoscopy, which is called UBE, is a relatively new endoscopic technique that is performed through one-sided access with two separated ports. Unlike other endoscopic approaches, UBE is not confined by the working tube or the working channel. It is based on arthroscopic joint surgery. First definition of UBE in literature was made by Dr. Anthony in 1996 as modified translaminar epidural endoscopy in lumbar discectomies. Then the Korean opinion leaders, Dr. Yam and Dr. Son, have taken this technique to the next step, which is called innovation period of UBE between 2003 to 2013. They have developed UBE technique and extended its application spectrum to all spinal stenosis and fusion surgeries. The basic principles of UBE are the following: creating potential cavity, triangulation, and adjustment of fluid irrigation. Unlike the joint, the lack of natural space on the lamina makes surgery a little more complicated. That is why creating a workspace is one of the essential components of UBE surgery. And there are many benefits of UBE, including less tissue trauma, less bleeding, less postoperative pain, and rapid recovery time as compared to open spine surgery. Compared to uniportal endoscopy, UBE doesn't require an expensive, fragile, and spatial toolkit. In most cases, arthroscopic and standard instrumentation is sufficient. In UBE, two portals move independently from each other to all directions. This free handling makes it easy to perform maneuvers, which is an advantage for beginners. UBE provides excellent magnification and a clear operative field of the ipsilateral, contralateral, and sublaminar space. In particular, the contralateral sublaminar space can be easily viewed using a 30-degree endoscope. Another advantage of UBE is that endoscopic trajectory is the same as microsurgery, which makes it easier to learn in the training process. UBE has a long learning curve, and it requires the advanced technology. If the surgeon is experienced with open spine surgery, overall technical performance may not be difficult, but for the beginner, initial making working space, keeping fluent saline outflow, controlling epidural bleeding, and bony drilling may be challenging and may require practice. UBE can be performed in the cervical, thoracic, and lumbosacral spine for different pathologies. Many degenerative spine cases can be operated by this technique. The contraindications of UBE are as follows: complex trauma, oncology, multisegmental instability, high-grade spondylolisthesis, advanced spinal deformity, some ocular problems. We suggest beginners to choose a simple discectomy by the left side approach in early phase, which may reduce the difficulty of practicing. Applying zero-degree endoscope at the beginning may help the surgeon adapt to the UBE surgery more quickly. Additionally, standardized training program and practicing on models or cadavers are of great help to shorten the learning curve. General anesthesia is commonly used for UBE. The patient is placed in flex prone position on a radiolucent table. In addition, we recommend that keeping the patient's head slightly above the lumbar spine to prevent complications related to increased intracranial pressure due to saline irrigation. There are two basic approaches in UBE, which is depending on the pathology. If the pathology is on the medial of mid-pedicular line, paramedian approach is preferred. If the pathology is on the lateral of mid-pedicular line, paraspinal approach is chosen. Skin entry points is very, very important to successful UBE surgery. There are some radiologic landmarks defining the skin points. For the paramedian approach, midline, intervertebral space, and medial interpedicular line are identified on the AP view. Two entry points are made 1 to 1.5 centimeter above and below the intervertebral space on the medial interpedicular line. The distance between two portals should be approximately 2 to 3 centimeter. For right-sided paramedian approach, both ports are created slightly more caudal on the right side. For the paravertebral approach, two portals are made along the imaginary line connecting the transverse process, which is 1 to 1.5 centimeter far from the vertebral body of the target level. Two skin incisions are made 5 mm and 7 mm in length horizontally on lesion site. Second incision is a little bit longer in order to make free outflow of irrigation fluid. A small incision and small outflow can cause water congestion, and these impaired water dynamics, and this can cause muscle edema. Both dilators are reached the spinolaminar junction, passing through the multifidus triangle, which is called Dr. Son's space. Our goal is to reach to this point without crushing or over-retracting with any muscles and expand it with blunt dissection. If there is not enough experience in creation of working space, this will lead to extension of operating time. After skin incisions, two dilators are inserted through the entry points under the C-arm, and the triangle is created on the lamina, which is called triangulation. This is the most important step in UBE technique. For beginners, one of the most basic pitfalls is difficulty of triangulation. If the surgeon cannot see the devices directly, it is not easy to match two handheld devices in a place. So the surgeon starts with a fluoroscopic guidance, although most of this step is done mainly by feel. To do the initial successful workspace, two distal portals must be formed a triangle on the lamina. This triangulation has been related by the distance between the incisions. If you make incisions far from each other, it is very likely that you will not see your instruments. If you make incisions too close to each other, your instruments get blocked or fighting in space. So distance between two incisions must be 2 to 3 centimeters. So getting into right triangulation is very important. For UBE, excellent hand and eye coordination is required for surgeons. The experience is quite similar to playing a computer video game, with the player looking at the action on the screen while their hands moving the joysticks and buttons without needing to look at the controller itself. In the early phase of learning, the instruments may be lost under the endoscopic view and even enter the wrong intervertebral space for the reason of multiple activities of endoscope and instruments. Correct placement of the endoscope and instrument is required for a safe procedure. Taking the left side approach, the endoscopic portal is located on the cranial side and the working portal on the caudal side. For right-handed surgeon, the triangle is addressed to the spinolaminar junction for paramedian approach, to the laminofacet junction for paraspinal approach. So identification through the endoscope of the spinolaminar or laminophyseal junction is critical for starting with the bone removal. Maintaining continuous fluid irrigation is another most important factor in UBE. For this, arthropump can be used under the pressure control. Optimal hydrostatic pressure should be kept about 30 to 50 millimeter mercury. Or natural pressure due to gravity can be used. Water outflow on the skin incision must be checked during surgery to avoid increasing epidural pressure in the spinal canal. If the flow is stopped after inserting of instruments in the working portal, a little cut of fascia under the skin could be helpful. If flow is not good, the back muscle would look swollen and visual field is blurred by the bloody water due to water accumulation. Another common pitfall is run into a bloody field. A small amount of bleeding during operation may complicate the surgery, and operation time extend mainly from struggling against blurred vision. In this case, it is not recommended raising or squeezing the saline bag for high flow, which may lead to over increase of the epidural hydrostatic pressure. In most cases, continuous saline irrigation helps control the bleeding. Additionally, if we move the endoscope deeper and closer to the pathology, we can get a clearer view. Usually, the epidural vein bleeds, but we can frequently see arterial bleeding that comes from 3 branches of the segmental artery. They are known as articular arteries. If it bleeds, we will see the screen as a red curtain. The epidural bleeding can be more effectively managed by the low voltage RF under the continuous irrigation. The RF generator should be set on the less coagulation and ablation intensity mode when the epidural space is exposed. Bone wax can be used if bleeding is bone-based. For hemostasis, gel foam or hemostatic agent also can be used. Systolic blood pressure should be kept 100 millimeter mercury. If the bleeding cannot be controlled, we should keep in mind that turning off the irrigation and waiting for 2 to 3 minutes will provide a spontaneous clotting. Now I would like to show some video. For the beginner, anatomic orientation of the interlaminar area is important. We should know where is cranial side, where is caudal side. After that, targeting on the spinolaminar junction is one of the main keys for the orientation at the initial step for perimedian approach. This area is the safe zone for the interlaminar procedure. After identifying the spinolaminar junction, it is removed the soft tissue around the interlaminar area by RF to create a working space. Hemilaminectomy is performed using high-speed burr and Kerrison punch. The bone removal begins from the spinolaminar junction and lower portion of the lamina of the superior vertebra until detaching the superior margin of the ligamentum flavum. However, during laminectomy, it is necessary to be very careful to keep the drill in the endoscopic view center constantly. For this purpose, the surgeon must move endoscope and drill synchronously. Kerrison ranger must be manipulated very carefully to avoid dural tear, not blindly bite. The bone drilling must be completed before removing the ligamentum flavum during the surgery. The ligamentum flavum is carefully dissected and safely splitted with a minimal resection. For the discectomy alone, we preserve the ligamentum flavum as much as possible. We don't remove all flavum, and we should make a ligamentum flavum flap with only partial peripheral resection. The axillary and shoulder area of the transversing nerve root are explored to confirm the position of the herniated disc. Then the annulus fibrosis is incised by dissector, and the herniated disc is removed by pituitary forceps. The RF probe is used for hemostasis. Then the skin incision is closed. Insertion of pneumatic drain is performed before skin closure if hemostasis is not enough. Overall, complications during the early learning period include dural tear, root injury, incomplete decompression, hematoma, and infection. For the early cases, proximal and contralateral sites of ligamentum flavum cannot be sufficiently removed. Complete hemostasis and blood pressure management during the surgery are important for the prevention of epidural hematoma. Intra-abdominal massive collection can be seen very rare, but it is mostly mortal. Increased intracranial pressure may lead to a headache, neck pain, or visual loss. As a result, UBE is a safe and innovative technique under the excellent magnification and illumination. Appropriate case selection, joining the training and cadaver courses are useful for shortening the learning curve. Some complications could be expected in an early learning period. More attention is required for the beginner to use instruments carefully in this technique. For the beginner, making working space, keeping fluent saline outflow, control of epidural bleeding, and successful bony drilling may be challenging and may require more practice. Thank you for your attention.
Thanks a lot, Dr. Shidam, for this excellent presentation. Is
You're
there a
welcome.
question from panelists? Thank you.
You're welcome.
And now we will shift to next speaker, Professor Kim. Please start sharing your screen.
It's me?
Yes.
Maybe after see them, maybe Dr. Hayachi have no. Can I give a talk now?
Hayati is not here now. So
Okay, I see.
Okay.
Can I share the slide? Okay. See my
Yes.
Perfect.
Okay.
okay. Thank you so much for invitation, and it is my honor to give a this time I hope to talking about the challenge of endoscopic lumbar intervallic fusion for adult spinal deformity. Because of that, with the development of the endoscopic spine surgery, now we manage near all kind of lumbar disc herniation and lumbar spinal stenosis and sometimes cervical pathology. Dr. Lohid already talking that, Shidem already talking that the decompression, and also now manage the thoracic decompression, also doing very safely and take excellent result about endoscope procedures. But I believe that maybe we generalize the endoscopic spine surgery as a spinal surgery. We should come the lumbar intervallic fusion with the development of the technique for adult degenerative deformity cases. This time I hope to talk about this. Sorry. As we already well known that with the increase the people's mean life, the degenerative spine increases so much, especially among them the degenerative deformity not only is scoliosis but also kyphosis increase so much. Because of that, to overcome this problem is a main issue in the not only spinal society but also in medical society and also social society. And I believe that endoscopic apply can overcome these problems, and we can the doctors and medical service can serve more good quality of life to the people and patient. And in the degenerative deformity cases, we already doing so many operation, and unfortunately before time we doing so big operation like this. So because of that, we give the some so serious damage of not only muscle but also sometimes nerve, and sometimes it make a flat back syndrome. Because of that, so many patients cannot take a good clinical result in the degenerative scoliosis cases. But to overcome these problems, several minimized option of treatment surgical technique developed like this lateral approach and some cases of anterior lumbar interval fusion for and also. But unfortunately, anyway, in spite of the minimized option of surgery, usually this surgery done under the multi-level and long-level fixation. Because of that, the patient still have some problem to take excellent clinical result. According to the previous study of degenerative kyphosis, we already well known that many professor talking that to take a good clinical result in the degenerative kyphosis, they're talking that the PI minus LL must be corrected within 10 degrees post-operatively. But in spite of like this concept, we tried, some doctors tried some correction of rule as this suggestion, but they talking that they cannot sufficient clinical result. Recently, Professor Seung Jae-hyun suggests another concept of degenerative deformity correction, and he talking that here. Yes, you can see the before time we mainly checking the PI spinal alignment from PI and pelvic tilt and sacral slope, but Professor Hyun talking that the should focus to the gravity line. Gravity line came from the center of acoustic meatus from here, and it should close to the hip axis here. In his paper, he talking that from here, center of acoustic meatus of gravity line to focus to the hip axis line, the patient result can take a more good clinical result. And anyway, this is my first case of endoscopic lumbar interval fusion for degenerative scoliosis cases. You can see the I'm also find the abruptly the endoscopic lumbar interval fusion can give the more good effect correct to the spinal scoliosis cases. Because of that, after then I tried many cases of degenerative scoliosis cases, and also I published this result by the World Neurosurgery. And in the cases of mild more than 10 degree cups angle and less than 40 degree cups angle, in spite of the degenerative scoliosis, using the endoscopic lumbar interval fusion, we can take excellent result of correction like this. And I saw so many cases of degenerative scoliosis cases greatly corrected by the endoscopically. But what is the reason of the endoscopic lumbar interval fusion have a more good correction effect of the degenerative scoliosis, also sometimes degenerative kyphosis? And I thought that what is the reason? And before time, endoscopic lumbar interval fusion mainly perform the transcambin approach. But I'm doing not transcambin approach, rather than I use the posterolateral approach of resection of the superior process and complete resection of inferior process. Because of that, we can release some adjust the point of the ipsilateral side and can make a sufficient this kind of restoration and sufficient correction of the spinal scoliosis point. Because of that, I'm not use transcambin rather than use the posterolateral. And you can see in the paper of my paper, I am always drilling from the lateral point to medial of the isthmus point, and then completely resect the inferior articular process, and also in superior articular process, drilling from the lateral to medial and resect this area completely. Because of that, in spite of the endoscopic lumbar interval fusion, we can release this area completely, and there have two very important advantages. That completely release the adhesion point, and secondly, we can insert more bigger cage in spite of the endoscopic approach. Sometimes I'm use the 15-degree height cage, and sometimes I use the 16-degree cage using this technique. And also another great advantage of endoscopic lumbar interval fusion for degenerative disease is the adhesive disc drilling. You can see here the, yes, sorry, yeah. Using the adhesive disc drilling, we can release the chronic adhesive point near completely, like this. And also use this technique. I already published two advantages using this technique. Firstly, disc height restoring is very, very nice, and so many cases near completely collapsed cases can restore near normal. Sometimes the overall correction can possible. Also, additionally, using this very well restoration of this height, spinal segmental correction also very, very nice, and sometimes can doing the overall correction is possible for degenerative scoliosis. And also reduction of spondylolisthesis can possibly accompany. Now, I published this technique all by the paper, and also recently another advantage is that can insert the 2 kg, and additionally you can see the 12-degree and 16-degree kg can possibly in spite of the process of the endoscopic lumbar interval fusion. Because of that, you can see the endoscopic lumbar interval fusion can preserve the structural preservation there completely, not only muscle but also facet, and but also around the structures, and additionally skin control can preserve near completely. Because of that, in spite of the short segment fixation, the proximal junctional kyphosis not happen near completely. I performed the degenerative kyphosis near 100 cases, and among them the 1 or 2 cases of degenerative kyphosis happen, and another case not happen proximal junctional kyphosis. Because of that, another spontaneous restoration, spinal alignment restoration is possible. Because of that, of the short segment and insufficient correction, finally the correction is done by the spontaneously using the endoscopy fusion. First, we checking the degenerative scoliosis cases. You can see this case only follow up the 6 months, and then in the APB you can see the degenerative kyphosis and all. Sagittal alignment is good. Only coronal alignment is problematic. And after operation, you can see this alignment corrected very overall correction. But I believe that in the 1 year, 2 year follow-up, this alignment will be restored. you can see that this patient followed the 1 year, 1 year female patient with the degenerative scoliosis cases of anterior epiview, but the lateral is not kyphosis. And then 1 follow-up, you can see the spinal alignment correction is very rare, and also the sagittal alignment also corrected well. And also another cases of 63-year female patient of degenerative scoliosis, you can see the some very scoliotic point of the right side and sometimes left side. And using the right side approach and left side approach like this right side approach, you can see the finally 1 year follow-up of the well correction, and not only front AP correction but also lateral correction is done very well. And also this another cases of this another cases of AP correction, degenerative scoliosis cases also, and also this another cases of degenerative scoliosis cases, and also this patient also followed the near maybe 1 year or 6 months follow-up. You can see the AP correction is done near completely. With this development of the degenerative scoliosis corrected by the endoscopically in the epiview, coronal view, I tried degenerative kyphosis cases, and also I already mentioned that there we can give the more bigger cage and some angular cage because of that. And also endoscopic approach can give some spontaneous restoration effect because of that, like this degenerative scoliosis and kyphosis you can see here, and the spinal degenerative is also some severe. And also you see it's a 2-level interval fusion only, and also here you can see that this correction is done very well, and also they have no PJK, and the spinal alignment corrected near completely, and the patient result also excellent. And this patient received the operation some another clinic maybe several years ago, and you can see some degenerative scoliosis and kyphosis together. And after removal of this point and try the short segment endoscopic lumbar interval fusion for above level, and also 1 year follow-up, you can see that this spinal alignment corrected very well in spite of the very short segment endoscopic lumbar interval fusion, and you can see. And also you see the PI minus L also so much more important. Already mentioned that Professor Hyun's suggestion is that some from central meatus to hip alignment corrected very well. And also this another cases of degenerative kyphosis also. And also after remove this implant, I tried again, and you can see the postoperatively and 1 year follow. You can see the spinal kyphosis also corrected excellently. Also, in some of cases like these degenerative scoliosis and kyphosis, firstly they corrected overcorrection, maybe like this. But this case is only 6 months. But you can see here, like this case is also degenerative kyphosis, posterior kyphosis. You can see here. But after follow-up, you can see that this spinal alignment for postoperative more over posterior kyphosis corrected 3 months and 6 months. Maybe I believe that the 1 month year corrected more sufficiently. I mean, I believe that I already mentioned that this came from spontaneous reduction effect due to the complete preservation of the around the structure, not only around the structure but also skin control preserved completely can make this. In conclusion, my final cases of so severe discitis, multi-level discitis patient. Also, you can see in the initial preoperatively the patient was 10 and also loss of lordosis, but in spite of the multi-level lumbar lordosis, you can see the preoperative alignment corrected postoperatively, and 6 months and 1 year, 2 years. You saw in this image. We before time we believe that after some confirmation of the fusion, that is not corrected the spinal alignment before in our concept, but you saw this corrected spontaneously by the time with the spontaneously, and you can see there have no PJK in spite of the previously degenerated above level cases. In conclusion, yes, still the endoscopic surgery and also endoscopic lumbar fusion still not completed, and also still ongoing process. But I believe that near all degenerative spinal disease can treated by endoscopically, but also in spite of the degenerative deformity cases can possible treated by the endoscopically in the future. Thank you.
Thanks a lot, Professor Kim, for this excellent presentation. And I have one question from your cases.
Yeah.
You have used two separate rods on one side, and this will make more stresses on this level. Have you encountered any complication from using two separate rods on one side?
One side, you mean that the cage insertion on side?
Yes.
Yeah, and I'm also published the paper. You can see there have some. I use the 3D printed cage, and also in the I compared the result of the endoscopic lumbar interval fusion and open transfemoral lumbar interval fusion. In the result, the fusion rate and substantial rate can take endoscopic approach can take more good result, meaning that the substance rate low and the fusion rate more high and more rapid. That arises from the completely preserve the end plate using the under the we can possibly try the only denudation of the end plate without damage of the vertebral body, because of that the fusion rate is in spite of the single cage only one side. It means that only one side the fusion can take excellently.
I am asking about rod. You don't use one rod to connect your construct.
What?
You have used two rods. Two rods.
Two wood.
Rod to connect your screws.
Screw, yeah.
To connect your screws, you have used not one rod to connect all screws.
Und.
You
Yeah.
have used two screws.
Und. Skin und.
Rod. Okay.
Sorry.
You can get it. Thank you very much. And now we will shift to next speaker, Professor Surayo. Please start sharing your screen. Professor Koishi, are you here? Okay, say, please go ahead.
Dr. Koshi, click on the share screen, please.
Me?
Yes, yes, we are waiting.
Okay.
And after introducing yourself, please.
Okay. You see me?
Yeah, you
Yes,
want to
yes.
put a full screen presentation mode, please?
Is it okay?
Perfect.
Okay. Today I'd like to talk on perfect return to play after endoscopic lumbar spine surgery in a professional athlete. My name is Koichi Saito, Professor Chairman, Department of Orthopedics, Tokushima University, Tokushima, Japan. I'm also a chairman of the Japanese Society of MISS. This is my COI. Okay, today, we are doing some kinds of endoscopic technique. So today's topic is for professional athletes. So for professional athletes, they don't like back muscle damage. So 8 millimeter skin incision, less back muscles. Here is good for a professional athlete. Okay, today's focus is 3. Number 1 is herniated disc. Second one is a discogenic pain. The third is type 1 modic change. For all pathologies, we are doing endoscopic surgery. Okay, herniated disc. Maybe you talked a lot today. Translaminar endoscopic surgery. The discectomy is the fundamental and basic technique. So before to perform another surgery, you should do this. This is a basic technique. Now we are using foraminoplastic as the in. First of all, the cannula docked onto the facet joint and drilled, then taking out the herniated nucleus propulsus. This is again the good technique to avoid the existing nerve root injury. Here, look at this 3-dimensional CT scan. The narrow foramen got bigger after foraminotomy. Now you can safely insert the cannula into the neural canal or into the disc space. So if you a good scale of this foraminoplasty, now you can take out the 5S HNP safely. This is a professional golfer suffering from a leg pain and strong back pain. And finally, she visited me, and I saw her and decided to do taking out the HNP using a fluid endoscopic technique. So see here the yellow dot line. So without foraminoplasty, it is very difficult to take it out. However, after the foraminoplasty, see here, you can touch the HNP and take it out. So this is before and after surgery. So HNP is removed and she could return the golfing again. This is the other female professional volleyball player. See, look at this, the left side, huge mass is compressing L5 nerve root, also L5 and S1. Both two nerve roots are impinged. So her muscle is weakened, dorsal and plantar flexion weakened, cannot jump. She, since she is an attacker, she needs to jump, but weakness, it's very difficult to can jump. So 5S1, foramen far out herniation plus intracanal herniation. Yes, we can simultaneously remove the mass from a transforaminal approach. See, after surgeries, no more HNP is pushing L5 and S1. And a couple of months later, the weakness completely improved. So she finally attended the Tokyo 2020+1 Olympic game as a national team. This is the take-home message number 1, translaminar full endoscopic lumbar discectomy. If you have a good skill of foraminoplasty, any type of the herniation, even at L5S1, can be indication for the translaminar approach. under the local anesthesia. Next topic is the discogenic pain. The discogenic pain is just low back pain. It not pushes nerves or no leg pain, no leg symptoms. The key word, please remember the two biggest signs. On MRI is the high intensity zone. See here the bright signal in the posterior annulus right there. The other one is toxic annular tear. This is an annular tear. You see during the discography CT scan. And with concordant pain, so it says toxic annular tear. How about HIG? It was reported by April in 1992. He said it's a pain generator of the discogenic pain. So you don't have to do the discography anymore if you see the HIG. This must be the pain generator. The other one is toxic annular tear. This concept was from Tony, my mentor in the United States. She mentioned about toxic annular tear in 2017. See here the similar findings, the discography, pain, and toxic tear. I can show one example here. She is a 23 years old female Olympian of the Vancouver game a long time ago. She here bright disc, but a strong lower pain, no skiing anymore. She here small bulging, but you can see high intensity zone is obvious inside of the annulus fibrosis here. I did discography, but this time discography only no CT scan, but see some leakage here to the posterior here, so yellow arrow. So discography, during discography, she said, this is my pain. And I injected the lidocaine and pain gone. No more pain anymore. And see here, 3 years later, the disc got a little bit degeneration. However, no bulging, no clear HIG, a little bit faint one, but no pain. And she could attend the Sochi Olympic game in Russia. So how about surgery? Mostly rehabilitation and block is effective, but in some cases we need a radiograph, radio pulse thermal angioplasty. So you see here, you insert the cannula, endoscope, and ablation for toxic tear plus HIG. See here the one good case. He has a HIG here. See. After I insert an endoscope, see you see here clear toxic tear. And I touched the tear, he said, oh, this is my pain. And abrasion there. Then I took the fragment, see the fragment is covered with the new vessels. And after that reached to the HIG, I saw the bleeding from the HIG. And using a radio pulse bipolar, coagulated. This is a case of a male professional soccer player, chronic lower pain due to HIG and TAT. He was suffering from 1 year, lower pain, 1 year. And finally, the physician introduced me and he came here. See here, severe HIG plus toxic annular tear. And I did that surgery. Now I'm in outside. From outside, see here, the bleeding from the inside of the disc. It's interesting. See here, the inside, near the toxic annular tear, see a lot of bleeding there. See here, this is the location of HIG, a lot of bleeding, see here. And I touched there, and he said, this is my pain. And still, red annular is over there, and I need to take out or need ablation. See here, radio pulse bipolar. See here, the annulus fibrosis is very easy to breathe. So this means new vessels coming into the disc with new nerves. So the gentleman, lower pain completely disappeared, and 3 months later, he returned to the soccer game. So transforaminal full endoscopic thermal adenoplasty. Please remember, pain generator of the discording pain is toxic annular tear and HIZ. Both pathologies can be treated by thermal annuloplasty using a radial pulse bipolar. Okay, final topic is type of modic change. What's the type of modic change? Modic change has three types. Number one is type 1. This is inflammation, T1 low, T2 high. Type 2, fatty marrow, T1 high, T2 high. Type 3 is sclerosis, type T1 low, T2 low. See here, female wrestling world champion shows end plate inflammation here. This is the right panel. The male martial art fighter world champions also showed type 1 modic change. Treatment is first of all intradiscal injection, the secondary fusion. But fusion is so big for too much invasion for athlete. Here, this is a picture with Professor Modic. The right panel is a picture in 2005. I met Professor Modic in Cleveland Clinic. The right side in Nashville. Recently, I met him in this year with his 18 years later. See here, finally, I came up with a new surgical technique called disc cleaning because this is inflammation. And I described my technique in the foraminoplasty outside in, remove the scar into the disc. Yeah, sometimes not cartilage anymore. Usually, a lot of granulation or scars inside of the disc. Then irrigation, a lot of the water. Then finally, coagulation of the new vessel from the end plate. See, type of modic change, a lot of new vessel from the end plate. So it's a very interesting findings. This is my first case, T1 high, T2 high. So this means a lot T2, type 2, but on SDIR. So strong inflammatory finding in the body and disc. So this is a type 1, type 2 modic change. So he was suffering from the low back pain for more than 4 years. And I treated him 1 year, but nothing changed, just pain there, type of modic there. So finally, I recommend him this screen surgery. This is my first case because he was a 32 years old young man. He doesn't like a fusion. He said, I want to continue my golfing, so no fusion anymore. So I did this screen surgery. 7 days after surgery, low back pain is completely disappeared. And 4 months after surgery, see here, no more inflammation. The type 1 converted to a type 2, completely type 2. Second case is a professional baseball player. This gentleman suffering from low back pain for 3 years. This is very difficult to continue playing baseball at a professional level. See here, his low back pain, BAS 8 at his activity, daily living, even just like walking, standing, just living 8, so strong. So you see the STIR image, strong, bright. So this means strong inflammation in the body along the end plate. I did this screen surgery on him, and he said 2 weeks later, no pain. He was so surprised because he was suffering from the pain 3 years, but after surgery, 2 weeks, no pain anymore. Then in 2021, he completely returned to the game. Okay, transforaminal full endoscopic disc cleaning. Low back pain with type 1 modic change can be treated conservatively. If it is not effective, surgical intervention is indicated, and think about disc cleaning using full endoscope. I'm a sports doctor, and in Japan, there are 12 professional teams. So many players coming to see me from all teams. So far, I did surgery on 18 players, and 100% return the professional level at the following season. For example, in 2017, I did the surgery for 2 top players, both of them disc surgery. And both of them were selected in the Tokyo Olympic 2020 +1, and he got gold medal. Interestingly, patient after back surgery received a gold medal. And last week, World Baseball Championship 2023, they got the gold medal again, and Mr. Kondo and Mr. Yoshida went there and got gold medal after back surgeries. Okay, thank you very much for listening to me. Thank you so much. Finish. Thank you.
Okay, I'm sorry, we have a little, hello, thank you very much, Sam, are you here?
Thank you. I'm here. Yeah, I'm here.
Yes. Yeah, I'm just waiting for Sam, he may have stepped away. Are you okay there, Sam? Maybe you had connections difficulty. Well, just thank you very much, Doc. Let's see, I want to see if there's any questions, and let me check the chat. Ahmed Sally said a nice presentation. Anybody have any comments or questions they would like the doc to answer? Okay. It looks like we may be moving on to the next speaker. And okay. I think Sam, we had a problem with Sam. There's no questions, Doc, at this point. So we're going to move on. Okay. Thank you very much. Okay. The next speaker is Sam disappeared. So we'll just have a digital break, it looks like. And certainly anyone in the panel can have a comment. Okay, we'll just hang on until Sam will get back, I'm sure. I'm sure there's some technical difficulty. Okay, I think what we'll do, we have a webcast pre-recorded from Malcolm. I think what we'll do now is play that. Okay. Okay, let me set that up. Okay. It's on cervical spine decompression. Right. And let me know if you can see it and hear it.
How's your first issue when you're in the hospital in Shanghai? What's your What's your first issue when you're in the hospital in Shanghai? Is she still active? Yes. Control, yes. Now, yeah. Would you say hello to him for me? Yes, yes. Okay. Thank you. Actually, Professor, you are on his Navy, and we were traveling international conference, and he were presented
Yeah.
award together. In the I think it's in June in the middle. Yeah.
Okay, I'm sorry about this. I'm sorry about this. We'll try it again. Hang on. Okay, I know there's no audio. Of course, it's no good without audio. Let me try to get this going here. Okay, I'm sorry about this. I'm sorry about this. We'll try it again. Okay, let me get the, and let me know if you can hear it or not, okay? I'm gonna screen share it. Okay. And let me know if you can hear it, okay? Can you hear that? Can you hear that? Sam, can you hear that? Can you hear that? I'm not getting any feedback from anybody. Can you hear that at all? I can't hear anybody. Can you please let me know if you can hear it? Okay. Okay. Okay, I'm sorry about that, folks. What, Sam? We're having a temporary problem. We'll get it going. Sam, are you there? Can anybody hear me? Nick, can you hear me?
John,
Yes, can you hear me?
I'm Dr. Rohit. I can hear you.
Okay, good, okay.
Nobody else was.
And let me know, I'm gonna try to play the video, okay, because Sam is not answering. He must have, let me put it on full screen. Okay, then we'll try it again. Just be patient.
Yeah.
Here we go, I'm trying it again. Okay, tell me if you can hear it. Can you hear me now?
I can hear you, John.
Okay,
I can
I'm
hear
gonna
you.
play it. Tell me if you can hear it.
Yeah, please play.
Can you hear that?
No,
No, you can't.
only your voice is coming.
You can't hear that, huh?
I think I am the only person who can hear you.
Oh, can other people hear?
Marisa will start. Okay, Dr. Sam has written something. Dr. Marisa will start.
Yeah, I'm sorry. Okay, Sam. We'll have to hold off on Malcolm apparently until we get things together. Let's be patient until Sam gets back. Yes, you can hear me. Can everyone else? I'm going to try to play this video once again.
Hello.
Hello, let me try to. I'm going to try to share this screen now.
Okay.
Let me try to share it and see if you guys can hear. We'll try, keep trying. Oh, okay. I think I got it. Okay. I think I got it. Okay. Now, can you see that? This is a different presentation.
Yeah, we can see that.
I'm ready.
Okay. I'll get off. Okay. Go ahead.
Thank you.
Oh.
Today is Spine Day. This is 7th anniversary to Academy. This is a glacier to Argentinian Patagonia. It's a beautiful place. This is our city in Buenos Aires. Thank you, Dr. Sameh Hassan and Dr. Malcolm Pestonji for this invitation to participate in this prestigious event. It's our second house, University of Buenos Aires in Faculty Medicine. This is our neuroanatomy department. This is our lab, neuroendoscopy lab. We created 201. Will we talk about the endoscopic trans-sacral approach in failed back syndrome? I'm Marisa Perez Solis. I'm a neurosurgeon. By definition, failed back syndrome is a persistent lumbar pain isolated or combined with radicular or referred pain after a surgical procedure. This is a failed back syndrome. One of the main causes is fibrosis. These endoscopic images show the nerve root with fibrosis. Trans-sacral epiduroscopy is a safe, minimally invasive procedure which allows visualization, can show fibrosis not yet seen MRI, diagnosis and treatment. Is less expensive and previous to neurostimulation. Trans-sacral epiduroscopy allows lysis of adhesions and fibrosis in mechanical ways, irrigation of Fogarty balloon, and with the use of laser and radiofrequency. This is a MRI, show the fibrosis, postoperative scar around S1 nerve root, but the severity of epidural fibrosis determined can only be determined by epiduroscopy only. 4 grades there are 4 grades, the severity of fibrosis. Grade 1, loose fibers and layers of fibrosis. You can see the root and the fibers similar to a spider web. The grade 2, fibers and layers of organized fibrosis showing no resistance to epiduroscopy. This is layers and fibrosis scars. And grade 3, dense and continuous fibrosis, which allows the advance of epiduroscopy. In this video, the neuroballoon open the fibrosis scar. In grade 4, dense and fibrotic material, which difficulties the advance of the epiduroscopy. Ross described in the original article, this is the original article, 4 grades the fibrosis. This phenomenon may be attributable nerve compression, restriction of nerve movement through nerve sleeves, or decreased flexibility of nerves due to tethering. The materials we use are introductor, endoscope, laser fiber, Fogarty balloon, saline solution, and medication. The type of endoscope is a flexible fiber optic scope, 1.2 outer diameter, and integrated fiber optical illumination. The steps to the sacral approach are puncture of sacral hiatus, dilation, introduction of a epiduroscope, adhesiolysis, and medication. It's a OR. And in this video, we insert the trocar and dilate. We enter the endoscope. This is a dolphin. We infuse saline solution slowly. No need for abundant irrigation to obtain high quality image. This is the introduction, the fiber optic epiduroscopy. In radioscopy, here we see the catheter in the L5S1 in the central area and L5S1 in the paracentral area of the disc. The endoscopic catheter shows in the ventral area of the epidural space. This is a catheter ascending the ventral area L5S1. In this video, the entrance, the epidural space, first image, and the bubbles objectify that we are in the correct space. In some cases, we use the grasping tool. This is a balloon. This is a neuroballoon working in the area. This is a nerve root. Then you can see the root. This is a neuroballoon catheter working the scars. This is a grade 3, 4, the fibrosis. This is a balloon, open the fibrosis. As This is a laser working in the area. The laser opens the fibers, and this video observe great scar. This is a root L4, and this is epidural canal. The laser working into canal, and this is a dural sac pulsing free the scars. This is L5S1 exiting the neuroforamen. This is a laser coagulated small artery, and this is laser working into the scar area. I recommend duration of the procedure 60 minutes, rational for success, adhesiolysis, reduction of inflammatory mediator with infusion, epidural administration. The medication we usually use. The procedure in OR with local anesthesia and sedation, ambulatory basis. This is our team, and complications relate to elevation of IP, headache, and retinal hemorrhage are very unusual. Paresthesias, pain at site of entry, the hiatal sacral, the hiatus. This is a more frequent complication, pain in the hiatal sacrus. The results, immediately post-operative, 95% patients achieve alleviation. 6 months, 85 patients refer 5-point average reduction in BIAs in the scale. At 2 years, more or less 15 patients require another procedure. This is our team. In conclusion, epiduroscopy is a safe and valid alternative to treat failed back syndrome, serving as both diagnostic and therapeutic tool. This is Andrea Sinagra. She's a neurosurgeon, my partner and me. Thank you.
Thanks a lot, Professor Mariz, for this excellent presentation. Is there any question from panelists? Okay, thank you. Please, John, start Professor Malcolm lecture again.
Okay, we'll give it a shot. I apologize to everybody. Okay, Sam, just let me know. Okay, I'm going to share it now. Okay. And hold on, let me get it full screen. Where is full screen? The full screen option disappeared.
Okay, just make volume loud.
Okay, okay, here we go, Sam. Okay, let me know, okay?
Perfume capital of the world.
Yes.
You hear it?
Yes, it's okay now.
Sorry to
Okay,
be not present over there because I'll be flying at that same time. Today my talk is on cervical spine decompression by UB technique.
Try to make it full screen.
As you see the positioning of the patient, the table is tilted for the neck to be horizontal by strapping the buttocks and bending the knee. It is important to be horizontal because you cannot perform an UBE operation if the table is not at horizontality. In the markings, you see the marking of the midline, the lateral masses line. You see the first needle coming in from above the superior mass and the second needle coming from below the inferior mass at the same level. The triangulation is on the lamina, near the spinal laminar junction, and from there you start the triangulation, the stripping of tissues until you reach the V spot. Now the anatomical importance of the V spot, my dear friends, is that the V spot is beyond the zygapophyseal joint, and that means that the cervical cord is no longer there and you are going to go in and you're going to work directly on the nerve root. So you're going to do a foraminotomy first. Here you see me performing a foraminotomy. It's a very fast, easy and a wonderful procedure to be done. Here you can see me drilling away the IAP, exposing the inferior mass, coming to the upper edge of the inferior mass, and then starting to nibble away the bone. As you open up the inferior mass and the superior mass, which you have already burred away, you come to the axilla and you can easily extract a posterolateral herniated disc. This is equally good for posterior osteophytic growths. Of importance is to define both the pillars, both the inner and outer pillar of the inferior mass, so that you can make sure that your nerve root is completely free. On removal of the discal material, you can see both the traversing and exiting root gripping the inferior pillar. Definite endpoints, proper landmarks, if they are understood, this surgery becomes an excellently easy surgery to do. I'm playing a video of a double level decompression. You can see that I have decompressed one nerve root. Now I'm sliding above the lamina and bang, I'm already decompressed the previous nerve root. So I have done two nerve roots through one set of incisions, just sliding above the lamina. You can do this for even 3 if you wish to, thereby making sure that you can do a lot of work. Sometimes in patients with single level myelopathies, I prefer to go over the top. I do an over the top extra flaval decompression of the contralateral foramen, and simultaneously I also do a ipsilateral foraminotomy. So bilateral foraminotomies with flavectomy in case the patient has symptoms of radiculitis, weakness of grip. And CT and other MRI imagings confirm the stenosis components also in the foramen. Or you see me at the same level now doing an end block, removal of the ligamentum flavum. I felt the flavum was quite adherent and I had to strip it very gently off the cervical cord. Having removed that, I still see a little flavum in the opposite foramen. I feel that it's still a little tight. I need to undercut it a little more. So I go across the open cord with a very small 1 mm kerrison rounger, with a very small footprint, and very comfortably, having made space above, I'm able to cross the midline and do the decompression that I desire to do. You can see the entire cervical cord free and the decompression going well. Of importance is making space above. This is the ipsilateral superior pedicular corner, showing the free nerve root flowing out and making sure there is no entrapment around that superior pedicular corner. Whenever you are doing a foraminotomy for discal purposes, it is important to check the axilla as well as the shoulder. But in myelopathy, I prefer to work more on the shoulder and a little less on the axilla. This is the image, the C-arm image showing a ball tip hook going through the opposite foramen. I'm now going to play a video of a patient with multi-level myelopathy and involvement of C4, C5 and C6 roots bilaterally with wasting, loss of muscle grip and loss of muscle power, and bilateral severe radicular symptoms. Patient had not slept for 7 nights. I've been doing 2 levels of hemilaminectomy. Between 4 and 5, I've removed the left-sided lamina. You can see the nerve root, and you will be now switching over above the pedicular corner to see the proximal nerve root. So you'll be seeing the C5 and the C6 nerve roots, both opened up at C4-5 and C5-C6. A similar procedure has been done on the contralateral side between C5-C6 and C6-7, the hemilaminectomy, the removal of the entire flavum across the spinal cord, retaining half the lamina, and doing bilateral foraminotomies has given the patient a complete recovery, complete improvement of muscle power, and now at 1 year follow-up, the patient is doing very well. There is no further progression of kyphosis because we have not touched the nuchal membrane. We have retained the floating tips of the spinous processes. So the muscular base being completely intact and undisturbed by endoscopy. We have a pretty decent long-term follow-up today of over a year. Here you can see the entire cervical cord decompressed. One must operate at higher blood pressures in cervical myelopathy. Therefore, the visual clarity is marginally poor. Here you can see me introducing the drain on the lamina. In this same patient, I am showing you the video of the additional foraminotomy, and you can see how nicely the nerve root has been decompressed in its path outside the facet joint around the pedicular pillar. Here you see the post-operative image where you see the floating tips of C4-5, C5, C6, and here you can see the pre-op and the post-op relief of the myelopathy, the CSF in the posterior part of the spinal cord. Coming to the next slide, I'm going to play a slide now of an ACDF surgery that has been done by me through endoscopy using a monoportal scope. But it's not only that, it's about introducing the cage with a scope, no use of any retractors, only a hemi-cut tubular retractor. Here you can see me going through the PLL and probing both the posterior vertebral borders. That is the removal of the fragment that was gone through the PLL. Here we are going through the gap in the PLL and we are pulling in that fragment that was out. After that, we will be expanding our footprint in the next part of the surgery by introducing a diamond tip burr. It's a flexi tip burr by Richard Wolf Company, and you can see me gradually burring away, expanding the bony footprint, but I prefer to keep the PLL intact, and those shiny fibers that you see posteriorly are the PLL fibers. As we go through, you will realize that the rent in the dura is different and the retained PLL fibers shines brightly different. I prefer to retain some part of the PLL fibers when I'm doing an ACDF in case I'm not hunting for any migrated fragments, because that helps to retain the cage and make sure there is no posterior migration of the cage. Now you can see the rent nicely. You can see the shining white fibers of the PLL and a little bony ooze coming along with the flow of water. This is the cage which has been introduced endoscopically. There is no retraction of the carotids. There is just movement and lifting away the tracheo-esophageal complex. You can see both the strap muscles on both the sides and the cage nicely placed in. However, I'm not happy. I want a little more vertically placed cage. So I'm going to try and lock it in, and I'm going to try and recorrect its positioning. Once the cage gets locked in, one can rotate the cage and yes, make it a little more vertical. Thank you. Thank you for all that I've been talking to you. I'm coming to my last slide. This slide is of 360-degree endoscopy, where I've done a C4-5 foraminotomy posteriorly for a posterolateral bony osteophytic disc, bony osteophytic complex, and a C5-C6 anterior pure endoscopic discectomy. This is the foraminotomy, the exploration of the root at the axilla and at the shoulder both, confirming that there is nothing there, doing the flavectomy, and subsequently now I have introduced the anterior endoscopic cannula at the lower level, and you can see me extracting a fragment and a pulsatile free dura over there, the fragment having come out of the PLL. I thank you very much for giving me this opportunity to address this August meeting. I thank you, Dr. Sameh, and EWNC and Academy for this privilege to be a part of this beautiful organization. Thank you once again. Thank you so much.
Okay, Sam, it'll get smoother next time. Over to you, Sam.
Okay, thanks a lot, Professor Martin, for this excellent presentation. And now we will shift to next speaker, Professor Anand Kevi. Please upgrade his account from attendees. Anand Kevi, and make me co-host. John,
Yes.
please make me co-host.
I'm sorry.
Co-host.
Oh, okay. Okay, Sam. You're muted. Are you in there, Sam? You're in. You should be in.
Also, Anand Kevi will start sharing your screen.
Hi, good evening. Can you hear me?
Yes.
It's okay.
Okay, I'll just share my screen.
You want to put it on full mode presentation?
Yeah, can you see the screen?
Yeah, perfect. Perfect.
Yeah. So good evening, everyone. And thank you at the outset. Thank you, Dr. Sameh and ENWC for inviting me for this prestigious meeting. I will be speaking on percutaneous lumbar endoscopy for foraminal and lateral recess stenosis under local anesthesia. I would like to introduce some newer concepts. Now, the slide here is actually the ventral dissection of the spinal canal, and that area marked as X in the upper slide is actually the extension of ligamentum flavum beyond the spinal canal into the foramen. And dear friends, actually, this piece of ligamentum flavum is the real culprit which gives rise to claudication symptoms in lumbar canal stenosis, and it is not always the central ligamentum flavum which is giving symptoms. Now, this particular hand-drawn slide shows us the pathology which we can approach through the foramen. So the area between these two red lines can very well be approached by percutaneous endoscopy under local anesthesia. We can also do this bilaterally for bilateral pathology and tackle any pathology which is compressing the exiting root, particularly in the intervertebral foramen. Now, this slide shows a horizontal line. So any pathology which is compressing and which is dorsal to this line, we cannot handle this through the transforaminal route. So we consider tackling these pathologies through interlaminar route, either by UBE or by single port endoscopic decompressions. Now, this is a practical MRI grading which shows several pictures. I would like you to focus on the right-hand side big square picture, which is actually showing that the exiting root gets compressed in foraminal stenosis through 4 sides. The upper 2 sides, which are seen here, is the bony margin and which is non-expansile. But the lower 2 arrows, the one here is actually the bulge disc, and the arrow here is due to the high riding of the superior articular process and the ligamentum flavum around it. And these 2 margins are very well modifiable. And with this modification, we can release this stenosis. Now, some food for thought. Dear friends, claudication and radicular symptoms can be unilateral or bilateral. Now, bilateral claudication can be due to bilateral foraminal stenosis and not always central stenosis. In case of bilateral stenosis, does the symptom start on the same day? And the answer is no. Commonly, it starts differentially. Now, those who have bilateral symptoms starting together may either have a congenitally narrow canal with a disc bulge and not flavum hypertrophy at all. Now, radicular pain and symptoms are actually due to the compromise at dorsal root ganglion, and it is not due to the compression from the posterior aspect of the dural sac. Now, the commonest symptom which we come across in clinical practice is at L4, L5. And we all know that the L4, L5 dorsal root ganglion is always inside the foramen. Now, lateral encroachment of ligamentum flavum to the neural foramen gradually increases from the upper lumbar levels to the lower lumbar levels. And this also tells us why it is more contributing to the stenosis symptoms. Now, with the advancing age, there is no change in the dimensions of the bony boundaries of the foramen, particularly after the skeletal maturity. What actually changes is the disc height. Disc gradually reduces due to the collapse and due to the herniation. And the next thing is the superior articular process tip high rides into the superior foramen. And the tissues around the superior articular process tip hypertrophies and makes the area more narrow, hard, and unyielding. Now, this exiting root is very tightly held in position with foraminal ligaments, and these ligaments do not allow it to move. And with foraminal compromise, this increases the vascular congestion around the root, and this is the main cause of the radicular symptoms as well as the claudication. Now, conventional treatment of foraminal decompression and detachment of lateral border of ligamentum flavum is difficult if we come from the interlaminar route, as the distance from the medial pedicle to the lateral border of the flavum at L1, L2 is just over 6 millimeters, but which increases to over up to 12 millimeters at L5, S1. And resecting all that ligamentum flavum located at the neural foramen, especially at the lower lumbar levels, is very challenging by posterior midline approach. Now, access to the lateral attachment of flavum at lower lumbar levels requires much more resection of lamina and pars in the traditional approach, and which can again cause iatrogenic instability. Now, this can be very well approached by transforaminal route, and endoscopic approach around the superior articular process is very easy. Removal of large spread of ligamentum flavum and the junctional tissue gives excellent clinical relief to the patients. Now, this is a line, this is called as a landmark line, the line passing through the inferior end plate of the upper vertebra. It usually touches the tip of the superior articular process. Now, in case of collapse and degeneration, the superior articular process tip will be cranial to this line. And you can observe this in the MRI pictures of your patients. Now, this is one study by Dr. Saeed Usman and his colleagues, which supports what I am saying, that if you do the decompression through transforaminal route, it actually achieves a much more larger decompression area rather than the interlaminar route. And also it is more safe and it minimizes the instability. Now, this is the endoscopic view, hand-drawn, which shows how we do the burring of the undersurface of the facet bone inside the foramen. And we actually try to release both the traversing as well as the exiting route. And we will actually see this in coming slides. Dear friends, the equipment required is not very technically demanding. These are the simple 3-4 instruments which are required for the transforaminal endoscopy. Now, this is a small video showing a down-migrated fragment in a 78-year-old gentleman. So, also foraminal stenosis. So, we approach this through transforaminal route under local anesthesia. So, what we are doing here is we have just undercut the lateral part of the facet, and we have reached that part of the lateral extension of the flavum in the foramen. And slowly, with the endoscopic carescence, we are removing the lateral extension of the flavum in the foramen piecemeal. As we are doing it, we are exposing the canal, and we can actually see the lateral extension, the lateral margin of the dural tube and the traversing route. So as we coagulate the tissues here, now we can see the dural tube clearly as well as the lower end plate. And now we can very well safely go beneath the dural tube to get the down migrated fragment out. So with one route and just one go, we have decompressed the central anterior aspect as well as the foraminal area. And this is given excellent relief to the patient. So here you can see the completely decompressed dural tube in the lateral recess. Coming to the next video, here you can see there is a foraminal stenosis due to the high writing of the tip of the superior articular process, as well as there is lateral recess stenosis due to the anterior osteophyte from the vertebral body. So the same approach through the transforaminal route. So here we are using an endoscopic burr to remove the undersurface of the facet, that is the superior articular process. Once the burring is done, we come across the hardened ligamentum flavum tissue. So with a small endoscopic cutter, we cut that hard tissue. And now what we see is actually the osteophyte, which is being chiseled out using an endoscopic chisel. So this was that anterior osteophyte seen in the MRI scan, which was compressing the dura from the anterior aspect. So once we break the osteophyte, we morselize that bone and we can remove it piecemeal. And once that is done, here you can see the completely decompressed lateral recess with the dural tube. And now as I'm turning the cannula, you can see the exiting route and the complete axilla is decompressed here. So you can see that the traversing route as well as the exiting route is very well decompressed. And mind you, you can do this surgery under local anesthesia with just minimal sedation. And it is extremely safe to do these procedures, particularly in old age and infirm patients. This is the follow-up MRI, which we can see that the complete recreation of the foramen, the osteophyte is gone. And this is the happy patient. Now one has to remember that the radicular artery passes just cranial and ventral to the root. So one has to be careful while working in this area. Another last example of foraminoplasty is a 59, 60-year-old lady, again showing compression due to the upriding or high riding of the superior articular process and the tissues around it, giving rise to unilateral symptoms. So same way we do the undercutting of the facet there. And it is just 3 mm of bone. So this does not cause any instability or further subsidence at this level. So once the tip of the superior articular process undercutting done, we come across the lateral expanse of the flavum there. Again, we remove it piecemeal with the endoscopic kerison. And once that is done, we come across the free dural tube. So this is the junctional tissue that is at the axilla of the exiting as well as the traversing route. So now we can see the exiting route here. And as I turn the cannula dorsally, we see the main dural tube and the lateral recess decompressed. So that's the axilla of the exiting route. And this is the traversing L5 nerve in the lateral recess. This is the post-operative MRI showing recreation of the intervertebral foramen with the free nerve. And this is the lateral recess decompression. Complications, yes, there can be dysesthesia due to handling of the dorsal root ganglion, but usually it is short-lived and very well controlled with analgesia. Dural injury is possibility, so this requires a lot of training and you have to be very careful. And another problem, as I've already said, you have to be careful when working in the superior part of the foramen to avoid injuring the radicular artery and preventing any bleeding. So friends, thank you very much for patiently listening to this. This is actually a stitchless surgery, and you all understand how difficult it is to handle a very old age patients with multiple comorbidities. Even doing procedures under general anesthesia is very difficult, and it has got a prolonged and protracted course in the hospital. All these things can be very well avoided by this technique of transforaminal endoscopic decompression under local anesthesia. And it does works wonders and adds years to your patients. And this makes the surgeon also very happy. So thank you, Dr. Sameh. Thank you, ENWC, and thank you, Neurosurgical Society, for giving me this opportunity to present my work. Thanks a lot.
Thanks a lot, dear friend and KV, for this excellent presentation. Is there any question from panelists? Thanks a lot, dear friend, for accepting our invitation and for excellent presentation.
Thank you, Sameh. Thank you so much.
And now we will shift to next speaker, Dr. Bhupesh Patel. Please start sharing your screen. Thank you.
Yeah, I'm audible now.
Perfect.
Yeah, hello. Good evening, everyone. Thank you for giving opportunity to present my part on endoscopic forum. Again, thank you, Same. So today I'm going to present on Cauda equina syndrome. Which one approaches better, transforaminal, uniportal, or biportal? So let's see case by case discussion. Here I don't have any theoretical discussion. I just present my cases and let's conclude the cases. So one is 85-year-old male with bilateral leg pain, unable to stand since 15 days, loss of urinary control since 5 days, bilateral lower limb numbness and constipation. So this is his clinical picture. You see the huge dorsal cyst. It may be arise from facet or we don't know the origin, but there's a huge cyst compressing all the descending nerve root, and there is a severe lumbar canal stenosis also. But we found something. On arrival, patient had blood pressure of 80/40. With blood investigation, we found there is silent MI, but we treated patient on ICU for 1 week, and then we took OR and did interlumbar endoscopy, monoportal endoscopy under local, and we put a epidural catheter in situ. If patient not tolerate local anesthesia, we can give epidural also. But fortunately, patient tolerated surgery well and had complete relief of pain post-op. We removed catheter after 1 week and his bladder and bowel function returned. You see the clinical picture videos. હમણાં કરતા હતા એમ કરો કરો હા સર સાહેબ કરો under local we did. So again, a 34-year-old male with severe low back pain with bilateral leg pain. Right side is more than left side. Right partial foot drop since 2 weeks. Bowel bladder involvement since 10 days. So walking distance is not able to walk more than 2 minutes. Standing time is less than 20 seconds. You see the X-ray. There is no instability on dynamic X-ray. Interlaminar window is pretty good. So MRI, you see the disc is everywhere. Huge herniation. Up migrated, down migrated, central, everywhere the disc is there. You can see in axial MRI also. So very big herniation. We did here. We just give 5 ml. So the one fragment here, big fragment is from here. So this is a final picture. You see the final picture of disc. Complete decompression of thecal sac. Fragment. Post-op MRI of simple. So he had a complete relief of symptoms on very next day. We keep catheter at least for 10 days and we gave a trial on 10 days. His bladder function on after 10 days, it returned. And he came back to all his day-to-day activity and after 45 days, 1.5 months. So again, 45-year-old lady came with only retention of urine, no radicular pain and difficulty in passing stool since 1 week, but no radiculopathy, no back pain. So it is called Cauda equina syndrome, mimicking as a conus medullary syndrome, because she doesn't have any radicular pain. It mimicking as a disc is herniated at LD12, L1 or L1, L2 level. But actually you see the disc is herniated in the sacral canal. It's huge disc in the sacral canal, and it's just pressing the caudal nerve root. But he doesn't have any radicular pain. So in this case, we did interlaminar endoscopy. So this is the axilla of S1, S2 nerve root. So I just, with cannula, I just make a space between S1 and S2 nerve root. You see the herniation is there. Again, I'm trying to make some space so that we can remove the herniation. So we removed two big fragments. Now you see there is a complete decompression. Even I just I just also retract the S1 nerve root on and decompress the shoulder part also. So any intradiscal, any herniation, we also remove that. This is retraction of after retraction of S1 nerve root. We also decompress intradiscal debulking also. You see the final picture. This S2 root, S1 nerve root, and there is no herniation below the, and there is no nothing in the Cauda sacral canal also. So now again, what do you think? Which approach is better, interlaminar or transforaminal? So we have seen many times in transforaminal approach, but wait, again he has a 24-year-old male with severe right leg pain since 2 months, not able to stand more than 2 minutes, not able to walk more than 2 minutes. He has a perianal numbness and difficulty in control urination since 4 days. Presented since last year. Okay, time. You see on MRI there is no instability. He is very young. Window is okay. Iliac crest is okay. You see there is a huge herniation at L4-5 level, more of central paracentral. I did transforaminal endoscopy in this patient. You see the final picture. I removed a herniation and also removed the phlegm from lateral recess also on the right side, because he has a predominant weakness on right side. You can see the final picture of decompression. So almost cord is decompressed from everywhere, and you see the herniation is almost 7 to 8 centimeter long. But here is very young, so I try to preserve as much as PLL as possible, because without PLL this collapse very fast and chances of recurrent herniation is very high. So I try to preserve the PLL also. Now he's after 1 month he started taking a weight around 20 kg weight, and he does all the day-to-day activity. He's farmer by profession. Again, 37-year-old male with left leg pain since 3 months, sudden onset of left leg weakness with complete foot drop since 3 days, not able to walk, loss of bladder control in 1 day, catheterized outside due to urinary retention. We did emergency surgery on same day. It came with last Janmashtami. You see no instability on flexion extension. You see the huge herniation at L3-4 level. So the central disc and all sacral root and descending nerve roots are also compressed. So we did transforaminal endoscopy on same day. So these are, we just with a dural dissector we made a space and cut the PLL, because here we want to do a complete decompression. We want to see the thecal sac completely, so that we don't miss anything.
સકાળે ખુલ્લું હતું જ્યાં જવું હતું આપણે ગયા હતા એસપીઆઈ બાજુ તો મળે છે અડીને તો છે
So again, I just see the anything I should not left because it's a Cauda equina syndrome. So we don't want to take chance. We have to decompress entire thecal sac in entire length. So after 15 days, he came with walking and foot drop recover. His bowel bladder function also recover very well. This is with transforaminal endoscopy. So his pain relief on same day, power improve in within 15-20 days. We removed catheter on 15 to 16 days. So full recovery of motor function 40 days and bladder symptom in 1 month. Again, 145-year-old male with severe right hip pain, weakness since 1 week. He is wheelchair bound, uncontrolled urination and constipation. Sorry, image is not that good, but you can see there's L1, L2 disc herniation, huge disc in L1, L2 level. So that again, you remember at L1 and 2 that there is almost all the lumbar root are yet to exit. So there is a thecal sac containing more amount of nerve root. So even herniation is not huge. Then all the nerve root got compressed because of crowding of nerve root L1, L2 level, and patient may have urinary symptoms early. We did transforaminal decompression again in this patient. Sorry for poor video quality, but he again you see the huge herniation we removed from his back and he recovered completely. Pain relief on same day, motor function. This patient took almost 2 months to recover motor function. His bladder symptoms need 3 weeks to recover, but complete recovery at 3 months. And after 3 months, he returned to his job. Now, which one is better? Transforaminal or interlaminar? But again, wait. You can see the one more case, 50-year-old male with severe bilateral leg pain. Right is more than left since 1 month. Urinary retention since 15 days. Not able to walk because of weakness. Standing is less than 30 minutes. Bilateral foot drop. You see, huge herniation at L4-5 level. With down migrated herniation is reaching almost L5-S1 level. You see again with severe stenosis. Herniation with stenosis also. So phlegm is also hypertrophied, disc is also herniated. So it's very bad stenosis. But we did biportal endoscopy in this patient. We removed the disc from contralateral axilla also. Contralateral L4-5 axilla, you see the here nerve root. So I did this UB from left side. So most of the work I did decompress contralateral side first and then removed everything from contralateral side and try to decompress a thecal sac on both sides. You see on this left side, we can retract the thecal sac very well, and disc is also removed. Phlegm is also removed. So we achieved almost 360-degree decompression. So below the L5 vertebral body, there is nothing down in the body. On contralateral side, you can clearly see in the contralateral nerve root, very good space between traversing nerve root. And again, you see the axilla completely free. So we removed the herniated disc from axilla as well as both sides. This big 3 fragment. So again, which approach is better, when and why? So in conclude, I have shown you all 3 approaches. So it is always debatable which approach is better for particular pathology. Again, choose the approach which surgeon or operating surgeon is most comfortable. Most important here is 360-degree decompression of thecal sac. If we should not compromise decompression on selecting particular approach. So with the approach which gives you complete decompression, we should choose that approach. But for me, the soft disc pathology at L4-5 or above, I would do transforaminal first, because thecal sac here handling is very less, and all the thecal sac is contained in sacral nerve root and motor nerve root. So if you do the transforaminal approach, if possible, with soft disc pathology, there is not much stenosis, then it is the best approach. At pathology at L5S1, interlaminar is better, because the iliac crest and large facet going through transforaminally is difficult, because we most of the time landing the anteriorly, and we may not able to remove completely, and we cannot able to confirm the decompression whether we have removed the fragment completely or not. Always listen to your master again, because it will shorten your learning curve. Thank you. Again, thank you, EWNC and Dr. Same, for giving me opportunity to present my case. Thank you everyone.
Thanks a lot, Bubash, for this excellent presentation and for case discussion that you have showed us. Thank you.
Yeah.
Is there any
Okay.
question from panelist?
Should I stop my?
Thank you.
Thank
During
you.
the past lectures, we have tried to show you how endoscopy can manage your patient well, and you have to come to see in our first congress to see more and to discuss more. That's why you have chose the theme of our congress this year. Come to see endoscopy.
Definitely. We will meet you at that time, and we'll have a lot more discussion for endoscopic regarding endoscopic. Thank you.
Yes, we will enjoy if all of you will join us.
Yeah, sure.
And now we will shift to next speaker, our dear Professor Zia Jukaslan. Please start sharing your screen. Thank you.
Good morning, everyone, and or good afternoon, shall I say. Thank you very much, Dr. San, for including me in the program. And Dr. Patel gave a beautiful presentation. I'm very impressed what he's able to do with the endoscopic approaches here. Quite impressive. Let me see if I can share my screen here. Right, let's see if we can do that. Let's see. All right. Are you able to see my screen by any chance?
We're able to see the slides, not the complete screen yet.
How about
There
now?
we go. Perfect.
All right. Well, thank you very much. Thanks for including me in the program, as I said. And we're going to change a little bit gears here. The previous presentation was really focused on minimum invasive approaches. This is probably going to be exactly the opposite end of the spectrum, where we're going to try to look at some of the maximally invasive approaches in treating tumors, namely spinal chordomas. This is really based on our large experience in treating all sorts of spinal tumors, over 5,000 cases now. But as you can see here, the primary tumors make about 10% of the cases that we treat, and we have used all approaches in treating these tumors. This is looking at our en-bloc resection experience now many years ago. But the point of that slide is really, you can see the big yellow slice here, which really corresponds to the chordoma. So we really perform the en-bloc resection, these aggressive approaches, primarily in patients with chordomas. And you can also see other sarcomas listed in here. There were a number of also benign aggressive tumors as well. This is the work that we've done with the AO Spine Knowledge Forum over the years. We've looked at large centers around the country, around the world, who do perform these types of procedures. And we were able to collect a large number of primary spinal column tumors from these various centers. And you can see, again, the chordoma is the most common malignant tumor that we see in the spinal column. And you can note that we close to 400 plus cases were collected from this series. If you look at the overall survival, anytime we perform any appropriate procedure, meaning that if you were able to remove the tumor with negative margins, the patients lived longer, and their time to local recurrence was also much longer when you did any appropriate surgical procedure. That's highlighted here with the solid line. When we looked at this based on our own experience with sacral chordomas, for example, again, we were able to demonstrate that anytime you were able to achieve a negative margin, the patients actually did quite well. If you left the operating room with positive margins, and you can see many of those tumors did recur over a short period of time, and many of these patients eventually died. Yes. I think there's somebody microphone on the call here. So I just want to draw your attention at the various types of chordomas that we see, subtypes of chordomas, because the surgical implications are different here for these tumors. The most common ones that we see are the conventional and chondroid chordomas, but also there are rare cases. About 5% of the cases are differentiated chordomas, and a few percentage are poorly differentiated chordomas. So the en bloc resection probably makes a huge difference in conventional chondroid chordomas, whereas the role of en bloc resection remains to be defined, at least in my view, for the differentiated and poorly differentiated chordomas. And the differentiated chordomas, as you know, brachyury staining tends to be negative, and the poorly differentiated chordomas have a specific genetic mutation. SMARC1BC gene is absent, or INI1 expression is absent. And these tumors tend to behave very aggressively, like a sarcoma. Poorly differentiated chordomas are mostly seen in younger adults in the clivus and the cranio-cervical junction and upper cervical spine. And this demonstrates the survival differences in these different surgical, the histological subtypes. As you can see, the conventional chondroid chordomas do fare better than those poorly differentiated chordomas in this particular series. Not every patient requires an en bloc resection. Here's one of our cases where this patient had a upper cervical clival region chordoma, initially had intralesional resection at an outside institution, subsequently had multiple recurrences over the years, and then presented to us with spinal cord compression and myelopathy. And we had described this approach many years ago now, showing a trans-cervical endoscopic route, where the same approach that we use, transodontoid screw fixation, for example, with image-guided navigation and an endoscope to be able to resect this tumor completely. And then the patient was subjected to additional stereotactic surgery. And these are some of the instruments that we used at the time. You can see this beveled tubular retractor that is fixed to a arm that's attached to the bed, and then the setup in the operating room, image-guided navigation here, typically attached to the Mayfield head fixator, endoscopic setup, where you can see what you're doing there in the operating room. And you can see in the pre-op and post-op images here, one can achieve excellent decompression of the cranio-cervical junction. I mean, this patient lived a few more years after that, unfortunately died of progression of the disease eventually, despite multiple resections. Another patient here, which sort of illustrates some of the challenges, some of the lessons that we learned in the cranio-cervical junction. It's a large chordoma involving the upper cervical spine. You can see the extension of the tumor into the spinal canal. It's encircling the vertebral artery on one side. And we designed, and it's a very old case, but I think illustrates the challenges. Here's a posterior approach, the first stage of the operation, where the upper cervical spine, thoracic spine is exposed, and we have screws implanted already. And then we do a multi-level laminectomy in the cervical spine. The head of the patient is to the right of the screen. And you can see the decompression of the thecal sac. The C2, C3, C4 nerves are ligated and will be transected. You can see the tumor coming through that. You can also see the vertebral artery, both on the right as well as on the left side. They both have been skeletonized and separated from the thecal sac. We typically put a silastic barrier here in order to separate the plane so that we can find this dissection plane during the second stage of the procedure. And you can see how the silastic is embedded, and these are the ligated nerve roots here. And this is the extensive construct at the time we used, given that we didn't really have appropriate instrumentation. This sort of a homemade construction here in the craniocervical junction with wires and so forth. And the second stage was performed using a transmandibular circumglossal approach, as you can see here. There's a skull-based approach that we borrow from our skull-based surgeons. This allows you to have all this anatomy fully exposed and have a nice exposure of the craniocervical junction. Some of the important critical structures that are crossing the field, the lingual nerve, hypoglossal nerves, are all clearly visualized. And this is how it looks like in the operating room. The edge of the mandible is up here. The trachea and esophagus is reflected from right to left with this malleable retractor, and you can see the tumor here pretty clearly. Remember, this tumor has been disconnected from everything else except for the top and the bottom rostrum and the caudal end here. Here's the carotid bifurcation. Here's the vagus. Here's the IJs exposed here. You cannot really see the top of the tumor very well here. Then we go ahead and split the mandible, as I've described before, and you can see the mandibulotomy here, and this lateral, the circumglossal approach right around this tongue. We carry this, cut the floor of the mouth and carry it all the way down to the pharynx, and then you have the entire exposure from the clivus all the way down to the lower cervical spine. Tumor is behind the vasculature here, and you can see the hypoglossal nerve crossing your field here. This is after the tumor is extracted. You're looking through the mouth. This is the close-up view of the carotid on the right side. Here's the vertebral arteries on the left side. The right one is sacrificed and left with the tumor, and this is the ligated nerve root you can see from ventrally. Now, we initially attempted to reconstruct this with a fibular graft, and you remember that this patient had an occipitocervical thoracic fixation in the back, but this is a highly unstable area now, and we attempted that with the fibula and a cage, literally while the patient was in the hospital, coughing and so forth, and this failed very quickly, and then we take the patient back to the operating room and then salvage the patient with this construct where a cage was designed to function both as a cage as well as a plate, and the cage was anchored to the remaining arch of C1 and C5 levels here. And this is the artist illustration showing the construct you have that was sort of put together, and here's a specimen that is removed in one piece, and that's how it correlates to the MRI image. As you can see here, even this vertebra that has T2 signal change in it has tumor and the postoperative specimen. We learned that when you're reconstructing this area, particularly if you remove the lateral mass of C1, you need to really reconstruct the lateral mass, not so much the anterior column, because as you can see here, odontoid processes and really no axial loading capability. All of that is really transmitted through the lateral mass of the cervical spine. And to illustrate that, I put this case here, and this is a cervical epithelial sarcoma case that again involves, similar to the other case, even more so, as you can use all the way up the clivus, involving this C2 and C3 region, all the way down to C4 here dorsally. And you can see the challenging situation here. The tumor has a much larger precervical extension encircling the vertebral artery on the right side. This tumor was also intradural, so extended through the dura into the through the nerve root into the dura, and then encircled the spinal cord. And you can see the spinal cord is in the middle. That is being severely compressed. Now, we again attempted to do a two-stage surgical procedure here, but interestingly enough, we were able to resect all of this tumor from a posterior approach. We did a hockey stick type of incision here, as shown at the top, and then exposed the upper cervical spine, did a multi-level laminectomy, and then opened the dura and separated the tumor from the dura. These are the artist illustrations showing the nerve roots were cut again on the right side, C1, C2, C3. And then the key to this operation was really to gain access to the contralateral pedicle and then being able to dissociate that. We also were able to disconnect it from the clivus as well as through the mid C5 vertebra below, and you'll see that in just a moment. So this is the situation in the OR with the intradural extension of the tumor. You can see it's encircling the vertebral artery, and the spinal cord. So we were able to unfold this, so to speak, and separate it from the spinal cord, and then we went ahead and cut the pedicles on the contralateral side to the vertebral, medial to the vertebral artery, medial to the transverse ramen here. And then we were able to really extract the whole thing from dorsally. When you do a hockey stick incision here and detach the skull base, completely all the musculature here, sacrifice the vertebral artery, and take the nerve roots on this side, it gives you a very large corridor to be able to work. And then if you can disconnect the contralateral side through the through the pedicles using a bone scalpel, that allows you to then extract the specimen through this opening. And this is showing how we were able to dissect this from the posterior pharyngeal wall and the ventral vasculature. And here is a specimen that sort of illustrates the situation here. The specimen was removed in one piece, including all the vertebral bodies. Here's the spinal canal where it used to be. This is the edge of the ventral dura that was left attached to the tumor. And then this is the patient's CT scan showing the cervical spine that's missing. Again, this is all done from posteriorly. Then we go ahead and reconstruct this with a lateral mass cage. So this cage is embedded underneath the occipital condyle on the right side and then carries down. It actually is attached to the posterior construct with multiple cervical lateral mass screws. This allows the weight to be transmitted from the skull down to the lateral mass cage, then to the posterior construct, and then more caudally, it will be transmitted to the anterior column through the pedicle screws. And this also shows the reconstruction of the dura here, which required 3 separate patches for us to be able to do that. Here's how it looked like in the operating room. The head of the patient's on the right side. The feet are on the left side. Here is a dural reconstruction. You can see doubling of the rod construct here. Here's the ventral cage. These are the cervical lateral mass screws that are embedded into the cage that's connected to the posterior construct. And this is the patient's postoperative MRI scan. It's showing a large pseudomeningeal cell, despite our best effort to reconstitute the thecal sac. But this patient really did not have any postoperative issues related to this and able to swallow and breathe without any problems. Obviously, this would have been a big problem if we had come through the mouth through a transmandibular approach. Then we would have to deal with this, and the patient would have been at risk of meningitis as a result of that. This eventually resolved without any intervention. Here's the patient's postoperative CT scope views. Here's the reconstruction images showing where the cage is situated and how it connects to the posterior construct with the full cervical lateral mass screws. And here's the rest of the construct. More recently, we incorporated into our armamentarium some of the image-guided navigation capabilities. We also tend to print, to do a patient-specific 3D prints of the tumor, which shows us the important anatomical structure that allows us to be able to plan the surgical procedure very effectively. This paper shows some of those examples here. Let me show you some case examples. Here are some of the chordomas. This is a chordoma, and you can see this is the Ewing sarcoma that we treated, and various types of 3D patient-specific printed models showing the extent of the tumor. That really allows us to plan the surgical procedure very effectively. Let me take one of these cases here. Here's the technology that we have in the OR, image-guided navigation, intraoperative CT scan, intraoperative tumor mapping capability, 3D printed images, and all that is available to us. Here's our experience using this type of approach in patients with sacral tumors. You can see a large, sizable sacral chordoma in the distal sacrum here. The patient's preoperative MRI is used to map the tumor. Then we bring the patient to the OR and do an intraoperative CT. And then we merge those 2 images and map the tumor on the CT scan in the OR. And then we use this mapping in the operating room to be able to resect the tumor and stay outside the margins of the tumor, which proves to be very, very helpful. Let me show you this. In this particular case, this patient has a large cervicothoracic chordoma. This patient presented with right-sided Horner syndrome and right upper extremity weakness. Actually was an ER physician. He thought that he had a Spear-Sulcus tumor, but the CT-guided biopsy of this proved to be a chordoma. And you can see the patient's 3D printed images here, and showing all the extent of the tumor, both anteriorly and posteriorly. You can see the common carotid and subclavian and innominate vessels here, and the extent of the tumor. The vertebral arteries inside the tumor here. Here's how we are using this in the OR. This is one case. This is another case where our student who was working with us at the time, showing to our thoracic surgeons where the position of the subclavian artery is during the anterior approach. This patient underwent a two-stage surgical procedure, first anteriorly using a trapdoor exposure. And you can see this allows us to open up the chest as in a clamshell fashion, and it allows us to see all the important structures here. This is an intraoperative CT scan that is done in the middle of the operation after the chest is opened. The patient's reference frame for navigation is attached to the patient's rib here, and the tumor map from the MRI is superimposed on the patient's CAT scan intraoperatively, and we can see the full extent of the tumor. Using image-guided navigation, then we can do these osteotomies through the mid portion of the vertebra. You can see right next to the tumor, and this is up and down. We've done that on multiple levels and disconnected the anterior spinal column from the contralateral side. And the second stage of the procedure is done from posteriorly, like we would do with a spherosulcus tumor. You can see here cervical thoracic construct, and then after the tumor is extracted here, you can see the defect in the chest here. And this is really aided significantly in the OR with both image-guided navigation and intraoperative tumor mapping and 3D printed images. Here's the tumor that was removed in one piece with negative margins. Here's the intraoperative CT scan, reconstructed images showing the construct after the bone graft has been placed, and showing the part of the chest wall that's missing. Here's the ghost of the construct, how this is put together. Here's another patient showing a large thoracolumbar region, chordoma. On the right side, you can see how this tumor was mapped in multiple planes, axial, coronal, as well as sagittal planes. Here's the 3D reconstructed tumor that's marked in red. And then you can see the patient's 3D printed image here, patient-specific model showing the extent of the tumor, and that's how it looks like on the MRI and the CAT scan. And this is in the operating room. Here, what we did an intraoperative CT, recorded the patient, registered the patient to the computer for image-guided navigation, took the patient's preoperative MRI scan, mapped the tumor and fused it with the CT scan. And then now we painted the tumor orange here. That allows us to stay right outside the tumor, come very close to it, but right outside the tumor, so we can really attain negative margins here. Here is the second stage of the operation. The first stage is done from posteriorly to stabilize the spine and to try to disconnect everything from posteriorly. And the second stage is going to be done through a combined approach, both through the chest and through the back. The nerve roots are still not able to be transected here because we didn't have access to them. After we came from the chest, disconnecting the rostral and the caudal, and we were able to start rolling the tumor away. And then you can see how that looked like through the chest. And then eventually we're able to amputate the nerve roots and tie them. This allowed us to extract the tumor. And you can see when you look through the back of the chest, the patient's back, you can see the chest cavity. We placed a towel here in the chest cavity to be able to demonstrate that. This is the patient's 3D printed image, both pre-op and post-operatively, and this is how it looks like on the plain X-rays, then the pre-op CT and MRI. And this is the last case I'm going to be sharing. This is the patient who has a lumbosacral region chordoma involving 3 levels. And this is, again, approach in 2 stages. First, from posteriorly using a multi-level laminectomy. All the nerves are dissected extensively into the retroperitoneal space. Everything is disconnected from the back. We have a double rotting construct here, pelvic screws, S2AI screws. And then we implant a couple of wires here. One is a thread wire saw. You can see this is a tomato saw that's implanted above the tumor, another one below the tumor, and we have another wire that's encircling the construct dorsally that will be used to reconstruct the spinal column anteriorly to secure the cage. Here's in the OR, that's how it looks like. The head of the patient's on the left side, the feet are on the right side. You can see extensile dissection of the lumbosacral plexus here. And here are the wires that are dorsally wrapped around the construct. And this is the thread wire saw. You can see that like small wire right ventral to the thecal sac. And the second stage of the surgery is performed using a midline laparotomy approach, and the vessels are then split, the IVC and aorta, and we then go ahead and retrieve our thread wire saws, the tomato saws, and this is it going through the L2-3 disc space. This is more caudally at the lumbar-cervical junction, and then we use them to cut the spine. And when you cut the spinal column and do the osteotomy, you can extract the tumor completely here, as you can see. And here's the patient's reconstruction anteriorly within a distractable cage that fits into that space. I put a screw here in the end plate above just to prevent some of the kick out. And also you can see the wires that are now being used that were encircling the spinal the construct posteriorly. These are now being used after being extracted from the front to secure the cage. And here's the patient specimen that's removed in one piece. And this is how it looks like in the OR through the midline laparotomy. This is the aortic bifurcation. Here, IVC is retracted to the side. And here's the cage anteriorly, wire in front of it. This is the L5 S1 end plate, or S1 end plate, and then L2 end plate above. And this is how it looks like on the X-ray. And you can see the reconstruction of this area. Now, the cage needs to have a perfect fit. And we did have cage kick outs before, and that either you have to couple this with a plate fixation or connect this construct to the posterior construct in some shape and form. We use the wires here. You can also use carbon fiber cages with full spectacles to be able to do that. And eventually, you can see the patient's specimen that's removed in one piece with negative margins. And this is the patient's MRI preoperatively. So I hope I was able to make the case that it's important for us to understand the biology of these spinal tumors, particularly when it comes to chordomas, the subtypes of chordomas, and then en bloc resection, particularly for chondrite and conventional variants, are proven to be effective in improving survival. And fortunately, with the recent advances in our surgical approaches and spinal reconstruction techniques, now we are able to resect these tumors for the most part safely. I don't want to underestimate the complication profile of these operations. We work with our plastic surgeons to minimize the wound complications postoperatively, and there are other numerous complications one can encounter, but for the most part, these tumors with appropriate planning and multidisciplinary approach can be executed safely and effectively. And I'll stop there and take any questions that the participants might have. I'm going to stop sharing here. Any questions?
It's an excellent presentation. Is there any question from panelists?
I'm sorry, I didn't hear the first part of it. You were muted for a second. Dr. Hassan?
Okay, thanks a lot, Professor Jukaslan.
Let me see what the question is. What's the question again, Dr. Hassan? I cannot hear you. You're completely muted.
Is there any question from panelists?
Any questions?
Yeah, yes, for me. But,
Go ahead, go ahead.
yes, I have a question. Have you experience with the anterior thorax approach, and which would you recommend for young neurosurgeon? I have experience with Aleph or approach, and also Olive, and pleural, retropleural approach. But
Yes.
thoracic approach is very difficult for a neurosurgeon.
Yeah, so the short answer to that, I think that I have had the privilege of working with cardiovascular and thoracic surgeons for many years. And I started out my training as a cardiovascular surgery resident. So I I got exposed to these approaches early on quite a bit, and I was comfortable with them. But for young neurosurgeons, really to get comfortable with these approaches, you need to work with your colleague in thoracic surgery and cardiovascular surgery. They have a lot of tricks. They know how to manage complications, and you have to get them on board to help you with these cases. It's very easy to get into trouble in the thoracic spine. The regular thoracic approaches, standard thoracotomies, are pretty straightforward. But when you start mobilizing great vessels and dealing with chyle leaks and stuff like that, it becomes much more complicated. And so I would urge you to work with your thoracic and cardiovascular colleagues. The other thing I have to emphasize is that they typically are not comfortable in operating around the spine. So you really have to guide them through what it is that you're trying to accomplish, and so that they can really help you. But you need to work with them.
Thank you. Thank you very much.
You're welcome. More recently, we have been doing some joint cases with our thoracic surgeons using the Da Vinci robot. And so robotic surgeries, we just recently did a very nice pancreas tumor, for example. We were able to disconnect everything from the back, and then they were able to come from the front and extract the tumor through the chest, and then they delivered through the subcostal approach through the diaphragm without doing anything through the chest. But all the ribs had already been cut from a posterior approach. So it's usually very helpful. Yes, looks like there's another hand held up. Yeah.
I have actually experience while I work in a complex spinal center, whereas orthopedic and traumatology, they can this approach, and it's very interesting also in the deformity surgery. For example, for Sherman or in young people with strange kyphosis, pre-dorsal stabilization and fusion is adventure and release for ventral paraspinal ossification. And also in this case is opportunity and naturally an ventral thoracic approach. I've also seen.
I think taking advantage of the talent around you is always a good idea. Dr. Pirzad is a question from Afghanistan. Dr. Pirzad.
Thank you very much.
Hello, thank you. Yeah, thank you very much. Good evening. Salam alaikum. Thank you. Nice presentation. I'd like to know your advice for how to prevent the recurrence and what's our decision for recurrence of chordoma. Thank you.
You're welcome. My pleasure. Thank you so much. Thank you.
Welcome.
Thank you. Thanks for the opportunity. I'm sorry I'm not going to be able to stay for the rest of the talks for today. I'm going to be excused if you don't mind. But Dr. Hassan, thank you so much for including me in the program. I really enjoyed it. And I look forward to seeing you in person sometime soon. Thank you so much. Bye-bye.
Sam, you're muted.
Do you hear me?
Try again, Sam. Go ahead. Sam, try again. Sorry, Sam, we can't hear you. Can you repeat, please?
John is muted.
Yeah.
Okay, I think he's asked me to start.
Okay, well, I'll introduce you, Abby.
Okay.
Yeah. I've known Abby for a while. She loves this platform. She's dedicated to teaching. She goes to Latin America. She's been in all parts of the world, and we appreciate her coming. Welcome, Abby. It's all yours.
Yeah, thank you, John. Thank you, Sam, for this invitation. John, can you hear me?
Yes.
Okay. So we are again shifting gears from endoscopic spine and from spinal tumors and radical resection to a very different topic of cranio-vertebral junction anomalies or basilar invagination. So basically, we deal with a lot of these cases, and a lot of our theories and philosophies come from this experience that we have been dealing with these cases in our center. So to begin with, the first accounts of basilar invagination was given by Ackerman. He saw the body setup of these people in cretins, and he thought that basilar invagination was a component of cretinism. It was only later that Retzius and Berg coined the term impressio basios cranii. That time, the terms basilar invagination and platybasia were used interchangeably. Both the terms were coined by Furchow, and the terms were used interchangeably, thinking that one is there if the other, both of them are normally present in conjunction. It was only later that this definition was changed when basilar invagination was defined as prolapse of the vertebral column into the skull base, and platybasia was defined as an abnormal flattening of the base of the skull. So this typically has a component of platybasia. This has a component of platybasia. This does not have a component of platybasia. So the two terms became independent of each other. They could be present together with each other, but also generally, if only one part, sometimes there was only basilar invagination without platybasia. So these are some ancient figures, and you see how the basilar invagination was looked at. They were looked at as anatomical and radiological curiosities because you did not have a treatment for this. So this is a drawing from Homan where the interior of the skull after removal of the brain, and you see this cephalic bulge of the odontoid inside and the tight foramen magnum that he has tried to depict. In Chamberlain, this is how he described basilar invagination. It is as though the weight of the head has caused the ears to approach the shoulders, while the cervical spine, refusing to be shortened, has pushed the floor of the posterior fossa upward into the brain space. But even then, they just remained anatomic and radiological curiosities, and people did not know what to do about them. Patients came with deficits, they came with many problems. And earlier, when the early treatment included, that was done by Chamberlain, it included suboccipital decompression with upper cervical laminectomy. He did this in 2 patients. 1 patient survived and 1 patient did not survive. So the results were quite dismal. The associated morbidity and mortality remained high. And the only treatment option given to these patients was suboccipital decompression with upper cervical laminectomy. Then came 1964, when Dr. Dastoor in my department at the KEM hospital started studying these cranio-vertebral anomalies, and they came out from the realm of anatomical curiosities into the more practical field of clinical neurology. The patients started being identified, and treatment algorithms were started being defined in the literature for these kind of cases. In 1987, Professor Atul Goel, he described this technique of plate and screw fixation for atlantoaxial subluxation. This was also from the Department of Neurosurgery at KEM Hospital. And he described this technique where the joint was open, the C1, C2 joint was open, the cartilage was denuded, the joint was stuffed with bone chips, and directly screws were applied into the lateral mass of C1 and into the C2 pedicle pars. And this was the treatment that was made for atlantoaxial dislocation. And this technique actually changed a lot of things for basilar invagination, as I will show you. So this was his first case. You can see the X-ray showing the C1, C2 fixation. So that time in 1998, the basilar invagination that they had seen in our department was divided into 2 groups, again by Dr. Goel. Group 1, he said, was basilar invagination without Chiari formation. So in that you see that there was the whole group 1 and group 2 was divided on the basis of the presence or absence of Chiari malformation. So in group 1, there was no Chiari. In group 2, there was Chiari formation. That time, the treatment for this, so basilar invagination was considered to be a fixed anomaly. So the treatment of this was thought to be ventral anterior decompression, and the treatment for this group 2 was supposed to be foramen magnum decompression. If during the procedure some instability was visualized, then both the procedures, especially the anterior approach, was combined with the posterior fixation. Later on, it was realized that atlantoaxial dislocation in many of these cases is not fixed. It is actually mobile and can be reduced. And this also changed the paradigm of treatment of basilar invagination. So you see this patient who had a fixed atlantoaxial dislocation, meaning on flexion and extension, there was no change in the position of the odontoid with respect to the atlantodental interval. And in this case, the joint was opened, the joint was distracted, and then fixed with C1, C2 plate and screws. And you could see how beautifully the reduction was achieved. This is again another patient. You can see on flexion and extension, there is no change in the atlantodental interval. Even when you apply traction in the ward, there will be no change in this. The only way that you can change this treatment is if you go from posterior and open the C1, C2 joint and do a C1, C2 lateral march plate and screw fixation. The earlier method of treatment for these problems was going anteriorly and removing the odontoid and then going ahead with the fixation. But this posterior approach of distracting and fixing the joint changed the whole paradigm. Then this was realized by Professor Goel again, that basilar invagination was nothing. It was not a fixed anomaly. It was not a developmental anomaly. It was due to malalignment of the facets and due to mechanical instability. So he again divided basilar invaginations into two groups, group A and group B. And this is one of the most well-known classifications of basilar invagination. So in group A, you see that the odontoid has gone up from the Wackenheim's clival line and from the Chamberlain's line and prolapsed into the skull base. This may be associated with or without a Chiari. There may or may not be a syrinx in this constellation of group A. Whereas in group B, the whole skull base, the whole spine pushed the skull base up. So the odontoid did not cross the Wackenheim's clival line. However, it crossed the Chamberlain's line and the McRae's line. And it was normally associated with platybasia, as you see this abnormal flattening of the skull base of the clivus. And this constellation was known as group B. More often than not, it was found to be associated with Chiari and syringomyelia. So it was realized that the joints are abnormally inclined. They are not fixed. They are mobile or actually hypermobile. And mechanical instability was the problem in group A basilar invagination. So you see these various pictures of the facets and you can see how they are. You can see how unstable they are. They are actually prolapsing. And in this, the whole joint C1 facet has come in front of the C2 facet, kind of like a spondylolisthesis. So basilar invagination is a disease of the atlantoaxial joint. It is a dynamic and progressive process, and it is because of the increasing slippage of atlas over the axis over a period of time. This process of slippage may be exacerbated by trauma. So basilar invagination was likened to lumbosacral listhesis, where you have the listhesis occurring at the L5-S1 level more commonly. Here you can see that the C1 facet is prolapsing over the C2 facet and listhesing over it. And this was the pathophysiology seen in basilar invagination. And the treatment was this C1, C2 joint opening, stuffing of bone chips into the joint, and doing a distraction and fixation. And this was published in the cover page of Journal of Neurosurgery Spine. Now I'll just quickly show you some cases. So this is group A basilar invagination. You see how the facets are abnormally aligned. There is no Chiari. You open the joint and distract it from posteriorly and do a C1, C2 fixation. Again, another patient with a severe basilar invagination. You come from posterior, look at the facets, how abnormally inclined they are. You come back and realign the whole system, and you see the realignment and the fixation of the cranio-vertebral junction. So quickly, just some cases with severe basilar invagination, all done by an only posterior approach, and a very good realignment and fixation was achieved in all of these patients. So this is again another patient with basilar invagination. You can see the reduction. You can see how the facets are aligned. To do this surgery is technically difficult, but of course you have to learn it. And once you learn it, then you know that posterior is the way to go, and you'll be able to do a majority of these cases by this method. You can see how the severe the basilar invagination is, and you can come down and do the reduction and craniovertebral realignment. Even patients with group A basilar invagination with facetal malalignment, with syringomyelia and Chiari, this was the fixation done, and you can see that the Chiari has resolved to near completion, and the Chiari has also resolved. And of course, the patient doing clinically well. After this procedure of C1, C2 fixation, the patients actually improve remarkably. You can see bedridden patients, patients that are wheelchair bound, coming in a period of time, walking to you, and with gratitude. You have the potential of giving them a completely changed life. You again see this facet. You see how the C1 is over the C2, and the C1, C2 distraction and reduction and fixation. So just quickly, I will show you many cases that we have done. We do a lot of these cases. And once we were doing this, we realized that while just doing the fixation, you are causing reversal of the long-standing musculoskeletal changes that are seen in basilar invagination by this indirect decompression and fixation. So torticollis, which was there because of the basilar invagination, it reversed in the immediate postoperative period. You see the neck, see how short the neck is. Immediately in the postoperative period, the dressing is also not out, and you can see that the neck has lengthened and the neck has become straight. And these are reversal of these musculoskeletal changes. You see this Chiari and syringomyelia. This is 48 hours after the fixation, and you can see that the syrinx has already started disappearing. The Chiari has resolved. So a lot of these musculoskeletal and neural malformations that are present in basilar invagination are a component of this, and they reverse after the treatment of craniovertebral stabilization. So this was our recent publication, not very recent, maybe 10 years ago, of 510 cases of group A basilar invagination treated by C1, C2 fixation. The problem in these cases is the anatomy is a little difficult and challenging to treat. And there are various methods that we ourselves have devised so that we can, have a better outcome, a better surgical management of these patients, especially those who are new in the field and those who want to train. So this is one such method, that is 3-dimensional models that we build that, that defines the anatomy of the region, especially the course of the vertebral artery. These models are based on real life models. They can be sterilized, they can be kept on your surgical tray. And, you can exactly pinpoint by looking at them, looking at the live patient, and the anatomy can be defined, and it helps you during the surgery. So in this, you see on this side, the vertebral artery is abnormally placed, going on the lateral mass of the C1. So accordingly, we plan the treatment to avoid injury to the vertebral artery. And you can see in this patient, the fixation was done. This is another patient where again, you see the vertebral artery is going above the lateral mass. So in this patient, on one side, we did a C1, C2 fixation, and on the other side, we just impacted the C1, C2 joint space with a spacer. So we have many ways of treating this, but these 3D models are a good help to at least the beginner neurosurgeon, especially in complex cases of basilar invagination, because it gives you a case, gives you a good overview of the anatomy. So if you see this case, this patient has abnormal vertebral arteries on both the sides. You see how abnormal the anatomy can be, and this helps during the surgery. If you cannot do a C1, C2 fixation, there are many salvage techniques that we have devised to help during the surgery. This is one such, where you do a caudally directed C2-3 facet screw, or a caudally directed screw into the C2 facet. Suppose there's a high riding vertebral artery, or there is an absent pedicle, or there is some abnormality in the C2. You can use these screws. You can use just isolated joint jamming in the C1, C2 joint. We don't do this much now because our experience is large, and we feel that the use of spacers is not that required, as long as you stuff the C1, C2 joint with bone graft. Also, in some cases, we are using this transcranial insertion of atlas facetal screw. When the joint is very high, then you just do a small little craniectomy in the region of the occiput and atlas, and you can put the facetal screws in the region of the combined occipitalized atlas. This is again double insurance atlantoaxial fixation, where one screw goes into the C1 and the second screw, the C2 screws, actually crosses and goes to the C1 also. So it is like a transarticular fixation combined with a C1, C2 lateral mass fixation. So that is a very biomechanical sound procedure. So as we've realized that the whole gamut of abnormalities in the craniovertebral junction revolves around these two bones and revolves around the facets. The whole craniovertebral junction is the hallmark of mobility and stability. The occipito-atlantal joint is the stable joint, and it is very difficult to immobilize, to make it unstable. And the C1, C2 joint is the unstable joint. So where there is stability, there is also mobility. So basically, atlantoaxial problems are problems of the C1, C2 joint and not of the occipito-atlantal joint, and the C1, C2 joint needs to be addressed. So all the problems begin in this region, that is the region of the facets, as I will show you in the later presentation. So these are the facets of C1. They're strong. They unite with the occipital bone, the condyles, as they rest on the superior surface of the facet of atlas. And this is the C2 bone. as you see that it is an atypical vertebrae. And the most important point in this vertebrae is that the superior and the inferior facet are not in line as in the other cervical vertebrae, but the superior facet is in front of the inferior facet. And there is this region here between the two facets. Also, the superior facet has the graving of the vertebral artery, as it may groove into it, and you might have a high riding vertebral artery. So this is when sometimes the vertebral artery comes all the way here and causes a groove in this region, and that is when it is prone to injury, and that is the problem of the high riding vertebral artery. So based on our understanding, facetal, we devised a classification of basilar invagination based on facetal alignment. So if you see this facet, in this, the C1 facet is in front of the C2 facet, and this is the classical type 1 facetal abnormality or facetal malalignment. This happens more commonly in group A basilar invagination, and we've already discussed the treatment for that. It is C1, C2 distraction and fixation. Now you look at this facet. The facet of C1 is posterior to the facet of C2, and this is the type 2 atlantoaxial facetal instability. This is commonly seen more chronic cases of atlantoaxial instability, more in group B basilar invagination or in Chiari malformation. So this is the second classification, second type, and this is the third type. This is also the second type, and the third type is when there is no malalignment of the facets, when the C1 and C2 are actually in alignment. You cannot make out radiologically that they are malaligned, and this is the third type, or the type 3 facetal instability. So type 2 and type 3 are not very obvious atlantoaxial instabilities, and we have termed both these coins together as central atlantoaxial instability. And understanding this fact opens the realms of treatment of craniovertebral junction surgery, as I will show you in the next slides. So as we evolved in the understanding of basilar invagination, it was realized that group B basilar invagination is also accompanied by atlantoaxial instability. So earlier, in the earlier classification where group B basilar invagination was treated with foramen magnum decompression, the philosophy changed and we started treating it with C1, C2 fixation. And this was our earlier experience with 63 surgically treated cases. Now to show you this, so you see this image. There is basilar invagination because the odontoid has gone up about the Chamberlain's line. There is no, it has not crossed the Wackenheim's clever line. You see the facets here, they are in alignment. You see the Chiari, you see the syrinx. You see how high the basilar invagination is. So what we have done is just treated with a C1, C2 fixation, no foramen magnum decompression of any kind. And this is the radiological image after a few months of surgery. You see the syrinx has decreased, the Chiari has resolved. Apart from this radiological improvement, you see clinical recovery in these patients in the immediate post-operative period that is not at all comparable to the recovery that used to happen earlier with foramen magnum decompression alone. And that is how the pre-treatment state and intraoperative manipulation of the facets showed that the C1, C2 junction was markedly unstable, and you could not detect it radiologically, but you could see it intraoperatively. So this is again basilar invagination group B. You see the Chiari, you see the syrinx. This is the 3D model because of the complex nature of the basilar invagination, and you see the fixation. The problem in group B basilar invagination is the joints are very high. There is a lot of component of venous bleeding, and it is difficult to reach this region. But of course, if you learn and have more experience, you will be able to do this C1, C2 fixation nicely. So again, another case with Chiari and syrinx, you see the type 2 facetal instability, and you see after surgery of C1, C2 fixation, the syrinx has decreased, the Chiari has resolved. So there are many, many cases. This is again another group B. Here the syrinx you see after fixation has nearly completely gone down, the Chiari is resolved, and the only treatment that we have done is C1, C2 fixation, no need of any kind of decompression. You see the facets, they are in alignment. So radiologically, there is no change. There is no evidence of instability. But when you open it, you will see the instability while doing these cases. So basically, it was realized that by Professor Goel that instability and basilar invagination are synonymous. If there is basilar invagination, there is atlantoaxial instability, and that needs to be addressed. So the treatment of basilar invagination moved from the era of decompression to the era of decompression on fixation, and now to the current era of craniovertebral realignment if there is a group B basilar invagination and or only fixation. So only stabilization of the C1, C2 region gives a good gratifying result of basilar invagination, and the transoral surgery has been pushed into the realms of history. Now going a little further, coming to the next craniovertebral junction anomaly that is more common, and that is the Chiari malformation. So this was our paper in the year 2013, where we realized that the Chiari, the syrinx, the basilar invagination are all part of a spectrum. And the core point of this spectrum is atlantoaxial instability. So this was our initial paper. And more recently, we have now published our experience with 380 surgically treated patients with remarkable clinical results and good radiological results. As you can see here, this Chiari and syrinx. This is only fixation, only C1, C2 fixation. You see the type 2 fascial instability, no change in the atlantodental interval. The Chiari has gone up, the syrinx has resolved, and the only treatment has been done is C1, C2 fixation, no foramen magnum decompression. So just show you quickly some more cases. So Chiari, syringomyelia, no facetal malalignment, C1, C2 fixation. The syrinx has completely gone. You can see here, the Chiari has gone up and the patient has done remarkably well. This is again another patient with Chiari malformation. You see the syrinx and you see the syrinx has resolved. Actually, we have stopped calling this Chiari malformation we call it as a formation, because it is just a natural protective phenomenon that comes in to protect the cord because of the atlantoaxial instability. So again, this is no bone abnormality in the craniovertebral junction, no basilar invagination, only Chiari with syringomyelia. Just a mild type 2 facetal instability treated with only C1, C2 fixation. You see the reduction in the syrinx and the reduction in the Chiari. Similarly, another patient, you see how remarkably the radiological improvement has occurred, and even more remarkable is the clinical improvement. That just a type 2 facial instability, no basilar invagination, no change in the atlantodental interval. This is again another patient, and you see the syrinx, and here you see the cord. The syrinx has completely gone. There is nothing wrong in no bone abnormality in the craniovertebral junction. The facets are completely aligned. So, but all we have done is C1, C2 fixation, no foramen magnum decompression. The patient has done clinically well, and you see the radiological outcome also. So we've used these patients in pediatric age groups with great results. We have used atlantoaxial fixation for Chiari and syrinx without any craniovertebral anomaly, and we are seeing the great results with this technique. Even in patients, when you have a failed foramen magnum decompression, what are you going to do? The only option that you have now is a C1, C2 fixation. And you can see here, this is a patient who came to us after a foramen magnum decompression done outside. You see the syrinx, and after C1, C2 fixation, you see that the syrinx has resolved. There are some of our own patients that we had operated long time back are now coming back with recurrent symptoms of foramen after failed foramen magnum decompression, and we are treating them with C1, C2 fixation. So you see another patient who had undergone a FMD, who had undergone a syringosubarachnoid shunt, and multiple surgeries, a VP shunt. And this patient came to us finally, and we did a C1, C2 fixation. And you see the resolution in the syrinx, and the patient did remarkably well. So this was our paper on the subject of fixation for failed foramen magnum decompression. Now because there were a lot of skeptical comments about this fixation techniques, we also tried this evoke potential while during the surgery. So this is a patient with Chiari formation with type 2 facetal instability. And as soon as the screws were tightened, bilateral, when the screws were tightened, we saw a change in the MEP. You see the MEP in this part. This is the preoperative baseline MEP. And after tightening of the screws, the MEP actually rose. The patient, of course, did clinically well. This is again another patient with Chiari and syringomyelia. This is the baseline MEP, and this is the MEP after the stabilization was done. And you see we normally see a 30 to 40% increase in the motor evoke potential after tightening of the screws. And this was our paper on the subject, where we have recorded this improvement in the transcranial MEPs. So basically, basilar invagination, syringomyelia, and Chiari formation are all related to atlantoaxial instability. It is at the center of the whole gamut of abnormalities in the region, and that needs to be addressed, nothing else. Sometimes you have idiopathic syrinx, where you don't know, there is nothing else, no craniovertebral junction anomaly, no Chiari, just a mild facetal malalignment. The patient presents with classical clinical features that point to an abnormality in the craniovertebral junction. And all we have done is a C1, C2 fixation. And you can see the remarkable result after surgery. The patient did clinically well, and the syrinx also disappeared. This is again another patient with a syringomyelia. Patient improved after C1, C2 fixation, and you see the resolution of the syrinx. Again, another patient with just syringomyelia, treated with C1, C2 fixation, and you see the resolution of the syrinx and the patient doing clinically well. So basically, basilar invagination, syringomyelia, and Chiari formation, atlantoaxial instability is the cause. These are all nature's protective formations to stall and delay the effects of instability, to delay the neurological deterioration. So these are some of our papers where we have relabeled Chiari a formation instead of a malformation. Chiari formation acts as a protective airbag. It comes in between the cord so that, there is no injury to the cord when the movement of instability occurs at the atlantoaxial joint. And basically, for basilar invagination, for Chiari formation, foramen magnum decompression surgery, can it become historical? I'm quite sure that it will become historical. And for those who are interested, this is our most recent publication on the subject on central or axial atlantoaxial dislocation and cranio-vertebral junction alterations. It is a review of our patients over the 12 years, and you'll see the remarkable results we've had with C1, C2 fixation. So to conclude, as the understanding of basilar invagination has evolved, it appears that mechanical instability is the cause, and craniovertebral realignment and or atlantoaxial fixation is the current management of this anomaly. And basically, to conclude, atlantoaxial stabilization is the treatment, occipital fixation is not necessary, foramen magnum decompression is counterproductive, and transoral and transnasal decompressive surgery are historical according to our understanding. Thank you very much. Cannot hear you, Sam. Increase your volume, I think. Yeah. Now I can hear.
Go ahead, Sam.
Thanks a lot, Professor Shah, for this excellent presentation. Is there any question from panelists? Okay, yes, thank you. And now we will shift to next speaker, Professor Kumar Sura. Please, John, start playing his lecture.
Okay, Sam, where is the lecture? Did you send it to me, the lecture?
Yes, the lecture on email.
Where is it at?
Your email.
Okay. You're gonna have to hold on, Sam. Do a little song while we're gone. Hold on. Just give me a second. Okay, Sam, what address did you use? What email address did you use? Probably an old one.
الموسي 88 الموسي 883.
Okay, can you go on to the next speaker, Sam? Well, I look for it. Is that possible?
This is the final lecture.
Oh, okay. Let me look at my other account. What email did you send it to, Sam?
I will forward it again to you.
Oh, okay. Hold on. Okay, send it again, Sam. I don't have it.
Okay, I have sent it to you. It's
Yeah, I'm gonna give
titled
you. I'm gonna give you my
thoracic
email.
spine.
Okay. Okay, Sam.
Okay, thoracic spine. I have sent it to your email.
Okay, I'm gonna give you my right email. Okay. And send it to that email. We'll get it done. Okay, there's my email. Send it to that, okay? You got it? You got the email?
Yes.
Thoracic full endoscopy, is that it?
Yes.
Okay, just give
Yes,
me a
yes.
second, okay?
Yes.
Okay, I need access. You need to give me access, Sam, because I sent it, you sent it to my Google Drive, okay? And I'm just waiting for permission to access it on the Google Drive, okay? Can you hear me, Sam?
Yes, yes, I will. Can I send it to you WhatsApp? Okay, sorry, Professor Kumar, for this interruption. I think we will
Okay,
conclude
you sent me
our
permission
session.
to access it, Sam? I haven't got the permission yet to access it.
Do you hear me, John? Do you hear me?
Yes, I can hear you.
Okay, I think we will conclude.
You just send it to jb@neurosurgical.tv. Okay. Sorry there. Okay, that's Sam. Okay, unfortunately, I guess we'll have to wrap it up. We can't access it.
Do you hear me?
Yes.
John.
Okay.
Yes. Yes.
Oh, you can't see me, right? Oh, God. Is Abida still around?
There you go.
Okay.
Sam, I can't get it. It's not... There you go.
Abida, is Abida Shah still around so we can talk a little bit about the techniques of the C1, C2 fusion? Where is
Okay,
she?
okay, you can do that, discuss, and we'll keep working at it. That's a good idea, Martin. discuss and we'll keep working at it.
Yeah.
That's a good idea, Mark.
Yes, hello, Dr. Martin, I'm around.
Abida.
Yes, hi, hello.
Yes, hello, Dr. Martin, I'm around.
Yes,
Yes,
listen,
hi, hello.
okay, so when we expose the C1, C2 joint, we have two anatomical obstacles. I mean, this is in normal anatomy. So we have the C2 root and the ganglion. Now, in many cases, you can actually work around that. You can do a little bit of drilling and then get to the joint somehow and displace the root. But lateral to it, you have the vertebral artery as well, and it's surrounded by venous plexus. And so can you just share a little bit your vast experience, because you're dealing with deformed anatomy in the area. So that's going to be even more complicated. So please share with us how to get to the joint.
So basically, first thing you have to remember is C2 ganglion is outside the spinal canal. First,
yeah.
Outside the spinal canal. John, can you first use an echo?
Sure.
John, can you use an echo? Okay. So the C1,
I am muted, so no echo from my side.
I think now we are okay. So the C1, this ganglion is outside the spinal cord. It lies on the dorsal aspect of the pedicle, just behind the C1, C2 joint. So in a normal situation, in a normal C1, C2 joint, you can either we generally retract the C2 ganglion upwards. So we can mobilize it and put it up, and then we work beneath the ganglion. In cases of high basilar invagination, so now with the experience, we are still able to get away without sacrificing the ganglion. But if you are unable to see the C1, C2 joint, you can easily just go ahead and cut the ganglion. It does not cause too much problem. At least most of our patients don't complain of numbness. And you separate it. The problem while cutting the C2 ganglion in an abnormal anatomy is the vertebral artery sometimes right behind the C2 ganglion. So when you cut the ganglion, you be careful on the back aspect that you don't injure the vertebral artery. Be careful on the back aspect that you don't injure the vertebral artery. I have done it, so I know.
All right. Well, that was very. Yeah, I'm sure. No, so that's very valuable to share with other colleagues who might not have gone to the area. I have, not very much, but I have. And so then the next thing is, like I'm fully on board with you. Actually, I would like to come to Mumbai one of these days and see a little bit some of the wonderful work you guys are doing down there. But anyhow, what is really the pathogenesis of these? You see, there's a lot of discussion about what's going on in the cervical spine in terms of degenerative disease. And then what you're basically sort of proposing is that this basilar invagination and that kind of dislocation is basically a special variant, if you want, of when you say instability, obviously it's not an acute instability, it's a chronic instability. It takes a long time and it leads to deformation. The same processes we see in scoliosis, in all other deformities of the spine. But here's my question: what really gets the ball rolling in this instability process? That's the first question. And the second question is, I'm quite willing to go along with the idea that the CSF, is the syrinx is forming as a part of an abnormal movement in the area with mostly flexion extension abnormal movements. And so maybe the white matter tracts are shearing off each other and then fluid comes in between and so on. But still, just elaborate. What are your current ideas about the pathophysiology about all of this?
Okay, so the first part of the question was about what triggers, what gets the ball rolling. So one thinking is that we see a lot of this in our country, in India especially, where birth practices, birth processes are not very refined. And sometimes there is a subtle injury in utero, which kind of triggers the whole process and starts the ball rolling. And as they don't present immediately, they present, if you realize that if the injury is a little more of the acute kind, they will present at the age of 18, 19, 20 years with a more prolapse of the odontoid into the skull base. Whereas if the injury is more subtle, it will take a longer time, like the group B basilar invagination. Those come at about 35, 40, 45 years of age. They don't come relatively early. The group A one comes more earlier, they come in kids and in adolescents. So one factor is birth trauma that could play a role in getting the whole ball rolling. Of course, this is just a speculation, but we do see a lot in our country. So, that kind of gives credence to the whole thing. And the second thing is the Chiari and the syrinx. The pathophysiology of syrinx is the same as that happens when the tonsil comes in and the micro instability causing the shearing, as you have mentioned. But what we are saying is because it is unstable, the Chiari kind of comes in and cushions the cord so that the cord is not getting the injury and the Chiari is blocking the bone from directly hitting the spinal cord and preventing the shearing that occurs. So it is acting like an airbag. Once the thing is stabilized, there is no need for that cushion and the whole process reverses. So that is the pathophysiology that we are thinking on this subject.
All right. So with regards to the instability component, which is really a flexion extension story where the whole head kind of drops forward and then there's a chronic deformation of the skull base, the angle of the odontoid with the clivus and all of that. But can we actually, a lot of this is ankylosed joints. It's all sort of fibrous together, and it's an inadequate attempt perhaps of nature to compensate for this abnormal situation. How about, can we on MRI, for example, study inflection and extension, abnormal CSF movements with regards to the Chiari situation, or even in plain X-rays, do we really see movements, C1, C2, or what is your take there, or what have you observed there?
See, in plain X-rays, you are not going to see it because you do not see the facets. The movement is at the facets. It is not in the midline. So first thing is you move laterally from the midline to the facets. In some rotational scans, dynamic rotational imaging, you will see a little subtle instability. This is what we have realized over the time. You might not see it in just a bang X-ray on flexion extension. Sometimes you see a posterior dislocation of C1, and that is a clear-cut indication of instability. Sometimes you don't even see that. Sometimes you see a posterior dislocation only on one side, not on both sides, a unilateral facetal dislocation. And sometimes you see it on rotation. So all these images, if you see, then you will realize. And now, as you know, we did do the CSF studies in the beginning. We did do flexion extension MRIs, trying to find out ways to document the instability. But as we have matured in the whole process, we've realized that once you see the Chiari, once you see a group B, Chiari 1, that it is unstable. So we don't even, investigate too much. And we confirm it by intraoperative, manipulation. You can easily see it. You move the C2 spinous process and you will see how unstable the area is.
Yeah, well, unilateral dislocation in the area is very famous as a direct cause of trauma in the context of facet joint fractures and so on. And it is radiologically kind of looking weird on the plain X-rays. As you say, we can't directly see it. No, I'm just saying this not because I'm doubting or this is a diagnostic test or so on, but here's my take. I would think that the neurosurgical community and the wider, even orthopedic surgeons who are involved in this, would come around perhaps a little bit, how should I say, it would form convincing arguments, to build the case of what is going on. because that's all, you know, like, unfortunately, us surgeons, we tend to have a little bit, we're quite confident, right? And so we're always confident of what we're doing, right? I mean, none of us is going to do something that he doesn't believe in. And hence, you know, so we're all out there saying, here's how I do the aneurysm, and here's how I do this and that. So you get my point, no? So
I get your point, and we are working on this. How to
so maybe that would be of
something.
value.
Yeah, we are working on how to come with something. Yeah, we are working on to show the instability.
Okay. I'd be very happy to come down to Mumbai and visit you. I'll put my email address in the chat, and I will, you know, you can send me an email or something. I think I have Atul's card anyway, I think.
Okay.
Okay.
You're
Thank
most
you.
welcome.
Thank you, and
You're most
excellent presentation. Thank
You're
you.
most welcome.
Okay.
Okay, thanks a lot for this excellent discussion. And now we will conclude this session. And sorry for Professor Sukumar, I will share his own record on EWNC YouTube channel. Now we will reach the end of this 2 great days of 7th anniversary of EWNC Academy. And we hope you all enjoyed that, and see you again soon. Thank you all.
Thank you, everybody.
Thank you, Sam.
Thank you, Sam. Goodbye.